Anemia is a blood disorder where the body doesn't have enough healthy red blood cells or hemoglobin, resulting in poorly oxygenated tissues throughout the body. This condition takes many forms, ranging from mild to severe, depending on the cause. Anemia in males is a hemoglobin below 13.5 grams per deciliter, or a hematocrit less than 41%. And in females, it's a hemoglobin below 12 grams per deciliter, or a hematocrit less than 36%. But those numbers can differ based on which guidelines you're using. Also, people with chronic respiratory diseases like emphysema or medical problems like malnutrition might have symptoms of anemia even at normal levels of hemoglobin and hematocrit. In addition, those living at altitude can have high levels of hemoglobin and hematocrit to help deal with the lower oxygen levels. So it's good to keep in mind that these guidelines aren't appropriate for everyone. Now, the most common signs and symptoms of anemia are dyspnea with exertion and at rest, fatigue, pallor, and a hyperdynamic state, like bounding pulses and palpitations. If someone is anemic, the first thing to look at is mean corpuscular volume, or MCV. An MCV of less than 80 femtoliters is low, so microcytic. Between 80 and 100 femtoliters is normal, so normocytic. And above 100 femtoliters is high, so macrocytic. Of course, some individuals might have a few types or causes of anemia mixed together, and that's where things get more complicated. Most microcytic and macrocytic anemias are caused by a problem in producing either red blood cells or hemoglobin, and in those situations we can measure the reticulocyte production index, or RPI, or corrected reticulocyte count, or CRC. This number is the percentage of red blood cells that are reticulocytes, or immature, and is normally between 0.5 and 2.5%. A person with anemia and less than 2% RPI means that their body is not capable of producing enough red blood cells. In certain normocytic anemias that are caused by the loss or destruction of red blood cells, the RPI is above 2% because the body increases red blood cell production to replace the ones that were lost. Now, microcytic anemia can be divided into four main types: iron deficiency anemia, anemia of inflammation in chronic disease, thalassemias, and sideroblastic anemia. To distinguish them, you should check iron studies, which include the serum iron, which is the free iron in the blood, the total iron binding capacity, or TIBC, which tells you how much unbound transferrin is floating around and is available to bind iron, the ferritin level, which tells you how much ferritin is floating around and already bound to iron, effectively storing it, and a peripheral blood smear. Iron deficiency anemia is most common, and usually there's a low serum iron, high total iron binding capacity, and a low ferritin. Low serum iron means that there's more unbound transferrin, and there's increased total iron binding capacity, and that there's less ferritin that's already bound to iron and storing it. This generally happens in people with chronic slow bleeding, where the iron in the red blood cells is lost instead of getting recycled. This includes women with frequent or heavy menstruation, or patients with colon cancer, which should be ruled out in older men through fecal occult blood testing. Another cause is pregnancy, due to increased iron requirements for fetal development. In some settings, iron deficiency anemia can be the result of not having enough iron in the diet. Treatment for iron deficiency anemia includes addressing the cause and giving oral iron supplements, which can be taken with orange juice, which is slightly acidic and can help with absorption. Common side effects of oral iron include nausea, diarrhea, and constipation. If oral iron isn't effective, or the side effects can't be tolerated, IV iron can be used instead. Sometimes the cause of refractory iron deficiency is a Helicobacter pylori infection, because the bacteria can sequester iron and it can cause gastric bleeding, or inflammatory bowel disease or celiac disease, both of which cause malabsorption. In anemia of chronic disease, there's low serum iron, low total iron binding capacity, and high ferritin. This basically happens because there's a lot of inflammation, and during periods of extended inflammation, the body likes to store away iron. Anemia of chronic disease often develops in people with chronic inflammatory diseases, like infections, autoimmune disorders, and various cancers, and typically resolves once the underlying condition resolves. Next, there's thalassemia, where everything might be normal in mild cases, so normal serum iron, normal total iron binding capacity, and normal ferritin, while individuals with more severe disease have elevated serum iron, decreased total iron binding capacity, and elevated ferritin. This is because the problem has to do with making the globin chains of hemoglobin. There are two types of thalassemia, alpha and beta. In alpha thalassemia, there's a mutation in the alpha globin genes that code for alpha globin chains, which are present in both fetal and adult hemoglobin. While in beta thalassemia, there's a mutation in the beta globin genes that codes for the beta globin chains, which are only present in adult hemoglobin. There are 4 alpha globin genes and 2 beta globin genes. So if more genes are defective, then fewer normal globin chains are produced, and the more severe the thalassemia is. If there's one defective alpha globin gene, there are usually no symptoms. If there are 2 defective alpha globin genes or 1 defective beta globin gene, then half of the genes are gone and there are mild symptoms. 3 defective alpha globin genes or 2 defective beta globin genes might result in mild symptoms in some individuals, while in others it can lead to severe disease. And if all 4 alpha globin genes are defective, that's incompatible with life, and the fetus usually dies in utero. Whereas beta thalassemia is not lethal in utero, because the fetal hemoglobin does not contain beta globin chains. To figure out which chains are missing, you can use hemoglobin electrophoresis. Usually patients with mild thalassemia don't need treatment, while patients with severe thalassemia are treated with blood transfusions. The dependency on blood transfusions for survival makes all subtypes of alpha and beta thalassemia fall into 2 clinically relevant categories. These are transfusion-dependent thalassemias, covering all the subtypes requiring blood transfusions for survival, and non-transfusion-dependent thalassemias, that do not require transfusions for survival. To prevent transfusion-related iron overload, people with transfusion-dependent thalassemias are given iron chelating agents that trap some excess iron and sweep it away through feces or urine. In sideroblastic anemia, there's high serum iron, low total iron binding capacity, and high ferritin. It's characterized by sideroblasts, which are basically immature red blood cells found in the bone marrow. These erythrocytes cannot utilize iron for the synthesis of heme, so iron accumulates inside the mitochondria surrounding their nucleus, forming a ring. Eventually, unused iron builds up in the blood and binds to the transferrin proteins, causing a low total iron binding capacity. Increased serum iron also leads to increased ferritin levels. Some causes of sideroblastic anemia are congenital, like genetic mutations, whereas others are acquired, like myelodysplastic syndrome, excessive alcohol use, copper or vitamin B6 deficiency, or intake of certain antimicrobial drugs. Diagnosis is based on bone marrow biopsy, which shows ringed sideroblasts when stained with Prussian blue, which is a pigment that binds to iron. And finally, for congenital cases, there might be genetic testing. Treatment depends on the cause, and could include stopping the use of alcohol or medication, if that's the cause. Some congenital cases respond to vitamin and mineral supplements, and in the case of myelodysplastic syndrome, it requires a bone marrow transplant. Now, if a person has macrocytic anemia, the next step is asking for a blood smear to figure out whether it's megaloblastic or non-megaloblastic. Megaloblastic anemia is more common, and it's caused by impaired DNA synthesis during red blood cell production, which leads to continuing cell growth without division. On a blood smear, there are larger than normal red blood cells, and hypersegmented neutrophils, which means that they have 6 or more lobes in their nucleus, when they normally have just 3 or 4. The 2 main causes of megaloblastic macrocytic anemia are vitamin B12 and folate deficiency, so blood levels of both should be checked to see if either one is low. If these 2 are not informative enough, also the blood levels of homocysteine and methylmalonic acid might be checked. Homocysteine is generally elevated with either deficiency, while methylmalonic acid is elevated when B12 is low, but it's normal when folate is low. B12 is found in animal protein and can be stored for 3 to 10 years in the liver. So people who avoid all animal products, like longtime vegans who don't take B12 supplements, can get B12 deficiency. And even if someone does eat meat, they can still get B12 deficiency if they're not absorbing it properly. Normally, meat or dairy is broken down in the stomach, and the B12 is released. Next, a protein made by parietal cells in the stomach called intrinsic factor binds to the B12. Then the B12 intrinsic factor complex moves all the way through the intestines to the terminal ileum, where special cells recognize intrinsic factor and absorb the whole complex. Now, various things can go wrong with this process, and that would cause B12 levels to fall. In pernicious anemia, IgA antibodies attack intrinsic factor or the parietal cells, and either way, this interferes with intrinsic factor's ability to bind B12, and subsequently get absorbed. In Crohn's disease, often the terminal ileum gets damaged. In people that get a gastric bypass, the ingested food passes through the stomach quickly, so even if intrinsic factor is produced, it can't get to the food to bind B12. Now, B12 is used throughout the body, so people with B12 deficiency develop a variety of neurologic symptoms. After confirming that there's a B12 deficiency, further testing should be carried out to figure out the cause. For instance, by looking for anti-intrinsic factor antibodies for pernicious anemia, or carrying out endoscopic or imaging studies in patients that might have Crohn's disease. When the cause of B12 deficiency is a dietary problem, it's treated with oral B12 supplement. When the problem seems to be absorption related, it could be treated with really high oral B12 doses, higher than 1,000 micrograms to allow for passive diffusion in the gut. Or with intramuscular B12 injections weekly to get the level back up, and then monthly. And this can be followed by oral supplementation if needed. Now, folate, also called vitamin B9, comes from leafy greens. And nowadays, many countries fortify foods like grains and cereal with folate. We have up to a 6-week supply of folate in the body, and this can get used up even quicker during pregnancy. So generally, people who get folate deficiency are pregnant women, or those with an extremely restricted diet for longer than 6 weeks. Unlike B12 deficiency, folate deficiency does not cause neurological symptoms, but is dangerous for fetal development. For this reason, all pregnant women must take oral folate supplements. Non-megaloblastic anemia is very rare, and it presents with macrocytosis with increased red blood cell membrane surface area, rather than DNA replication problems. It's generally associated with chronic alcohol intake, but it can also be caused by liver disease, hypothyroidism, certain drugs like chemotherapeutic agents or antiretrovirals, and metabolic inherited diseases. Another cause is myelodysplastic syndrome, which is where blood cells in the bone marrow do not mature, and this can be seen on a bone marrow biopsy. Treatment of non-megaloblastic anemia involves dealing with the underlying cause. Finally, there's normocytic anemia, which is generally due to a loss of red blood cells through a hemorrhage or due to destruction of red blood cells or hemolysis. Normally, red blood cells live about 120 days, but in these situations, they're lost earlier. So there's a reticulocyte production index of 2% or higher to try to compensate for the loss. In some patients with normocytic anemia, though, the reticulocyte production index might be less than 2%, due to production problems like in bone marrow suppression or chronic kidney disease. Bone marrow suppression is a decrease in the production of cells secondary to bone marrow malignancy or some infection or drugs. So treatment involves dealing with the cause of suppression. In chronic kidney disease, kidney cells don't produce enough EPO to stimulate red blood cell production. To confirm diagnosis, we should look for elevated creatinine levels, and this can be partially corrected with erythropoiesis stimulating agents, or ESAs. Now, a hemorrhage causes anemia only if the blood loss is severe, but blood tests are usually normal. External hemorrhage is easy to spot, but internal hemorrhage can be harder to locate, so imaging tests can be helpful. The key here is to stop the bleeding and give IV fluids or blood transfusions if needed. If hemolysis is suspected, then blood tests might show an elevated lactate dehydrogenase, or LDH, as well as decreased haptoglobin, and in some cases increased bilirubin, which comes from the breakdown of hemoglobin and causes the sclera and skin to look yellow, so jaundice. Next in hemolysis, a blood smear showing abnormal red blood cells can give us a clue to the cause. Causes can be acquired or hereditary, so let's go through the most relevant causes. In autoimmune hemolytic anemia, red blood cells are attacked by a complement protein called C3d, and either IgM or IgG antibodies. When the second offenders are IgM antibodies, the result is cold agglutinin, which means hemolysis happens in the cool extremities when it's cold outside. On the other hand, when it's IgG antibodies, the result is warm agglutinin, because it happens when it's warm. Also, it's important to note that cold agglutinin is associated with infections like mycoplasma and mononucleosis, whereas warm agglutinin is associated with lupus and drugs like penicillin and cephalosporin. In autoimmune hemolytic anemia, the blood smear shows spherical red blood cells, or spherocytes. Then the Coombs test is used to detect the presence of C3d and the offending antibodies on the surface of red blood cells. In the case of cold autoimmune hemolytic anemia, direct antigen tests will result positive only for C3d because IgM antibodies detach from the red blood cells upon warming. Conversely, warm autoimmune hemolytic anemia will be positive for both IgG and C3d. Treatment for cold autoimmune hemolytic anemia is to avoid the cold, while warm autoimmune hemolytic anemia requires treating the underlying cause, like stopping a medication that's causing it, or using steroids in case of lupus, and a splenectomy can be done in really severe cases to limit red blood cell destruction. Hereditary spherocytosis is a genetic disorder caused by defects in the structural proteins ankyrin, spectrin, or band 3. Without these proteins, the red blood cells can't keep their shape and become spherical. This can be seen in a blood smear, and a Coombs test is done to rule out autoimmune hemolytic anemia. The misshapen cells are less flexible than normal red blood cells, and they get stuck in the spleen, where they're destroyed by macrophages. It's diagnosed by the EMA test, where eosin-based fluorescent dye binds to red blood cell membrane proteins, or by the osmotic fragility test, where they burst when put into water. The treatment is a splenectomy to prevent hemolysis. Sickle cell disease is an autosomal recessive disease that's most common among those of African descent, and is caused by a mutated hemoglobin gene that encodes for an abnormal adult hemoglobin called hemoglobin S for sickle. Sickle cell is usually diagnosed in childhood with hemoglobin electrophoresis. When there's acidosis, hypoxia, or dehydration, the red blood cells sickle, and that causes either hemolysis or capillary obstruction, causing ischemia and pain. These episodes are called sickle cell crises, and can cause emergencies like vaso-occlusive crisis, splenic sequestration crisis, acute chest syndrome, or stroke. During a sickle cell crisis, a blood smear should be done to confirm that cell sickling is present. During a sickle cell crisis, IV fluids, oxygen, and pain control are used to manage the symptoms. Occasionally, exchange transfusion is needed if there's an emergency. Also, regular blood transfusions can be done, and iron chelating agents might be given to prevent iron overload. To prevent these attacks, patients get long-term hydroxyurea, which reactivates the synthesis of fetal hemoglobin to replace the abnormal hemoglobin S, so there's a lower chance of sickling. Glucose 6-phosphate dehydrogenase deficiency, or G6PD, is an X-linked recessive disorder that results in defects of the enzyme. Normally, it protects the red blood cells from oxidative stress. So in affected individuals, there's hemolysis when they're exposed to oxidative stressors, like foods like fava beans, quinine-derived drugs, certain antibiotics, and infections. A mild variant of this disease is common in people of African descent, whereas a more severe variant is found in people of Mediterranean descent. When there's oxidative stress, hemoglobin gets damaged and forms Heinz bodies inside the red blood cell. Macrophages in the spleen detect the abnormal red blood cells and try to remove the Heinz bodies by taking out a chunk of the cell. So these red blood cells look like something's taken a bite out of them, so they're also called bite cells. So a blood smear can show these bite cells and Heinz bodies. During a hemolytic attack, the deficient cells die, so testing G6PD levels acutely is not reliable. So diagnosis can be confirmed by a low G6PD level roughly 8 weeks after an attack. Treatment of the acute phase of a hemolytic attack might require blood transfusions. But to prevent an attack, it's important to avoid the triggers, and sometimes those with recurrent hemolytic attacks will benefit from a splenectomy. Finally, paroxysmal nocturnal hemoglobinuria is a disorder caused by a defect in the PIGA gene. PIGA codes for the GPI protein that's normally found in the cell membrane of red blood cells, and it binds to another protein called DAF. DAF blocks the complement from attaching to the cell and destroying it. Deficiency of GPI means red blood cells can no longer protect themselves from the complement, so they get destroyed and release their hemoglobin into the blood. This hemoglobin gets into the urine, and it makes it dark. This is particularly significant during sleep, when there's reduced respiratory rate, which leads to hypoxia and acidosis, and that promotes complement binding. Diagnosis is made by flow cytometry, which tests for the lack of GPI-linked proteins like CD55 on red blood cells. Transfusion therapy might be needed for acute hemolytic attacks, and no chronic treatment is needed in most cases. Eculizumab, an antibody against the complement, could be given to individuals with recurrent attacks to improve their quality of life. Alright, as a quick recap. Anemia can be microcytic due to problems making hemoglobin, normocytic due to bleeding or hemolysis, and macrocytic due to deficient DNA production. Microcytic anemias include iron deficiency, chronic inflammation, thalassemias, and sideroblastic anemia. To distinguish these, you can check serum iron, total iron binding capacity, and ferritin levels. In normocytic anemia, red blood cells are lost, so there's a reticulocyte production index of over 2% to try to compensate. In some patients, though, with production problems like bone marrow suppression or chronic kidney disease, the reticulocyte production index is below 2%. Finally, macrocytic anemia can be megaloblastic due to low vitamin B12 or folate, or non-megaloblastic, which might be due to chronic alcohol intake, liver disease, hypothyroidism, certain medications, metabolic inherited diseases, or myelodysplastic syndrome.
Autoimmune hemolytic anemia refers to increased red blood cell hemolysis, or breakdown, that results when a person's own antibodies target red blood cells for destruction. And this results in a lower than normal amount of red blood cells anemia. The disease is most often idiopathic, or without a known cause, but it can be related to a medication side effect or an underlying disease process. Normally, red blood cells, or RBCs, are made in the bone marrow and contain hemoglobin, which is an oxygen-binding protein that delivers oxygen to tissues. Red blood cells live about 100 to 120 days, after which they are recycled in the bone marrow or consumed by macrophages in the spleen, liver, or lymphatic system. Now, autoimmune hemolytic anemia is an extrinsic type of hemolytic anemia, because the immune system mistakenly believes our own red blood cells are foreign, or non-self structures, so it secretes antibodies against proteins found on the RBC membrane. If there had been a primary defect in the RBC membrane, then it would have been called an intrinsic hemolytic anemia. And usually, hemolysis happens in the spleen or liver, so this is considered an extravascular hemolytic anemia. Although, in severe cases, RBC hemolysis can also happen intravascularly, or inside blood vessels. Now, autoimmune hemolytic anemia gets classified as either warm or cold. Warm is the more common type, and that's when hemolysis occurs at temperatures greater than or equal to core human body temperature of 37 degrees Celsius. Cold autoimmune hemolytic anemia is much rarer, and it occurs when people's blood is exposed to cold temperatures, usually in the range of 0 to 10 degrees Celsius, like when a person goes out into cold weather during winter. Warm autoimmune hemolytic anemia is almost always due to IgG antibodies, termed warm agglutinins, that react with antigens, which are proteins on the surface of the red blood cell. The main red blood cell antigen that reacts to these IgG antibodies is the Rh antigen. When these antibodies bind to the antigen on the RBC membrane, they bind to the surface of the red blood cell and trigger a process called antibody-dependent cell-mediated cytotoxicity. In this reaction, immune cells, including macrophages, neutrophils, natural killer cells, or CD8 positive T cells, bind to the Fc portion of the antibody via a cell membrane receptor called the Fc receptor. Once bound, a conformational change occurs in the Fc receptor on the immune cell that induces hemolysis of the red blood cell. This may occur via direct cytotoxins, like superoxide granules from neutrophils, or phagocytosis by macrophages. Phagocytosis mostly occurs in the spleen, where there's a high density of macrophages, which can result in an enlarged spleen. In contrast, with cold autoimmune hemolytic anemia, the culprits are IgM-type antibodies, and the primary red blood cell antigens are termed L, I, and P. In the chronic form of disease, which is the most common, RBC hemolysis primarily occurs in the liver, via the complement system. The complement system is a group of plasma proteins that act together to destroy pathogens. Specifically, IgM activates the classical complement pathway, and the complement proteins eventually assemble into a membrane attack complex, or MAC for short. MAC is a specialized structure that drills pores in the RBC membrane, which results in RBC destruction. In the acute form of the disease, this process can also occur intravascularly in the toes or fingers, causing Raynaud's phenomenon. This is a fancy way to say that microemboli clog the tiny capillaries in the toes and fingertips, making them turn purple or blue. Now, no matter the type of temperature at which it occurs, hemolysis leads to a cascade of events. First, the bone marrow revs up and starts pumping out immature RBCs, called reticulocytes. Since these red blood cells are normal in size, approximately 80 to 100 femtoliters, autoimmune hemolytic anemia is considered normocytic. Additionally, with intravascular hemolysis, when RBCs are broken down, an intracellular enzyme called lactate dehydrogenase, or LDH, spills out directly into the plasma, so LDH plasma levels increase. Hemoglobin also spills out of the RBC, and some of this hemoglobin breaks up into heme and globin. Heme is converted into unconjugated or indirect bilirubin, which is then taken up by the liver cells and eventually secreted out with bile. Some of the bilirubin is converted into urobilin, which is what gives urine that yellow color. But if there's too much of it, the urine becomes a much darker color, like black tea. If there's too much bilirubin in the bile, that may cause bilirubin or pigmented gallstones to form. Finally, if more RBCs are broken down than the liver cells can handle, the excess bilirubin stays in the blood and causes jaundice, which is when bilirubin deposits into the skin and eyes, causing them to turn yellow. With intravascular hemolysis, hemoglobin is bound by a protein called haptoglobin, and they're excreted into bile and removed from the body through feces. So with ongoing hemolysis, haptoglobin levels decrease. Also, when haptoglobin gets overwhelmed, the rest of hemoglobin goes via the blood through the kidneys and into the urine, resulting in hemoglobinuria. Now, when hemoglobin is inside the renal tubules, it's reabsorbed by the cells lining the renal tubules. The heme component of hemoglobin contains iron, which is stored inside tubular cells as hemosiderin. Hemosiderin is an amorphous collection of heme, proteins, and lipids. And after a few days, when tubular cells slough into urine, this results in hemosideриnuria. Hemoglobinuria and hemosideриnuria can damage the kidneys, causing renal insufficiency. Finally, with extravascular hemolysis, RBCs are destroyed outside the vessels, and so haptoglobin is normal, and there's no hemoglobin or hemosiderin in the urine. Now, there are multiple etiologies for warm autoimmune hemolytic anemia, but most cases are idiopathic, or without underlying cause. In children, viral infections are a common precipitant. Other causes include systemic lupus erythematosus, lymphomas, and leukemia, to name a few, as well as some drugs such as beta-lactam antibiotics like penicillin and cephalosporins. Cold autoimmune hemolytic anemia, on the other hand, has different causes depending on presentation. With chronic disease, causes also include leukemia and lymphomas, while acute forms are more often caused by infections like viral pneumonia, mycoplasma, and infectious mononucleosis. The acute form of the disease is often referred to as paroxysmal cold hemoglobinuria and is more common in children. Autoimmune hemolytic anemia usually progresses slowly over days to weeks, but sometimes hemolysis occurs at a rapid rate over the course of hours, which is called a hemolytic crisis. Symptoms of hemolytic crisis include those of profound anemia, leading to a bounding heart rate, which is when the person feels that their heart is pounding, has a severe shortness of breath, and potentially signs of multi-organ failure from lack of circulating red blood cells. In chronic forms of the disease, symptoms include fatigue, pallor, and shortness of breath from the anemia. Jaundice or yellowing of the skin may occur due to the buildup of bilirubin, and there may be hepatosplenomegaly. Oliguria or low urine output may occur from renal insufficiency, if significant intravascular hemolysis occurs. The diagnosis of both conditions starts with routine laboratory work and hemolysis labs, which will demonstrate a normocytic anemia, and low haptoglobin as well as elevated reticulocytes and lactate dehydrogenase. Definitive diagnosis of warm and cold autoimmune hemolytic anemia gets made by the direct Coombs test or direct antigen test. The direct Coombs test detects if there are any antibodies bound to the surface of a person's red blood cells. To perform this test, a sample of blood is taken and placed in a test tube. Next, Coombs antibodies are added to the person's blood. If antigens are present on the surface of the red blood cell, the Coombs antibodies will bind and cause the red blood cells to agglutinate or clump together, indicating a positive test. In case of warm autoimmune hemolytic anemia, the direct antigen test will result positive for IgG and a complement protein called C3d, whereas with cold, it will only be positive for C3d. Treatment of both warm and cold autoimmune hemolytic anemia involves initial assessment of the degree of anemia with lab studies, like hemoglobin level. If hemoglobin is less than 7, transfusion is generally indicated. First-line therapy for warm autoimmune hemolytic anemia includes steroids, and refractory cases can be treated with splenectomy to decrease the degree of phagocytosis, or other immunosuppressive medications. On the other hand, for cold autoimmune hemolytic anemia, no treatment is usually required. For severe anemia, however, plasmapheresis may be recommended. This is where the blood plasma is filtered to remove the harmful IgM antibodies causing hemolysis. Alright, as a quick recap. Autoimmune hemolytic anemia arises when the immune system makes antibodies against specific antigens on red blood cells. With warm autoimmune hemolytic anemia, there are usually IgG antibodies directed against Rh antigens, and RBCs are destroyed via antibody-dependent cell-mediated cytotoxicity. With cold autoimmune hemolytic anemia, the culprits are IgM antibodies that bind to antigens L, I, and P on RBCs, and RBCs are destroyed following activation of the classical complement pathway. Most often, the disease is idiopathic, And treatment may involve corticosteroids for warm autoimmune hemolytic anemia and plasmapheresis for cold autoimmune hemolytic anemia.
Glucose 6-phosphate dehydrogenase deficiency, or G6PD deficiency, is a genetic disorder characterized by decreased levels of glucose 6-phosphate dehydrogenase, which leads to the destruction of red blood cells. Now, normally, as part of the metabolic process, our body produces free radicals like hydrogen peroxide or H2O2. Free radicals can damage the cells in many ways, including destroying the DNA, proteins, and the cell membrane. Now, we have a molecule in our body called glutathione, which acts as an antioxidant and goes around and neutralizes these free radicals. In order to function, these molecules need to be in the reduced state, where they can donate an electron to the H2O2 and convert them into harmless water and oxygen. However, this causes the glutathione to become oxidized, so before it can get back to work, an enzyme called glutathione reductase will use an NADPH as an electron donor and reduce the oxidized glutathione back into its working state. After giving up its electron, the NADPH will become NADP+. So to replenish the supply of NADPH, we have the glucose 6-phosphate dehydrogenase enzyme, or G6PD, which reduces NADP+ back to NADPH by oxidizing a glucose 6-phosphate. Glucose 6-phosphate is a metabolite of glucose, so we usually have a ready supply of this molecule as long as we're not starving. Now, G6PD deficiency is caused by mutations on the G6PD gene, which is found on the X chromosome, and thus is an X-linked recessive genetic condition, and it almost exclusively manifests as a disease in men, since they have one X and one Y chromosome. So if the one and only chromosome has a mutation, then they have the disorder. Women, on the other hand, have two X chromosomes, so those with an X chromosome that has a mutation still has another X chromosome with a normal copy of the gene, and thus females are usually carriers and only transmit the disease to their sons. The G6PD mutations can cause defective G6PD enzymes to be produced, and these have a shorter half-life, meaning they don't last as long as the normal enzymes. There are two common types of G6PD deficiency, a Mediterranean and an African variant. The Mediterranean variant is characterized by a more markedly reduced half-life of G6PD. Now, sometimes this can actually be an advantage since it provides protection against falciparum malaria. G6PD deficiency makes a parasite-infected erythrocyte more susceptible to dying from oxidants, which means it will also kill the malaria parasites. So, despite the obvious downside to having any of these diseases, they do offer an upside when it comes to warding off a malaria infection. In fact, because malaria has historically circulated in Africa, the genes underlying these diseases are thought to have conferred a natural selection advantage, and therefore became more common in the genetic pool. Okay, so now low levels of G6PD causes low levels of NADPH, leading to low levels of reduced glutathione. Now, G6PD is the only way for red blood cells to get NADPH, so they are especially susceptible to damage caused by free radicals. When these build up, it causes the cell membrane to become unstable, causing their lysis or hemolysis. Free radicals can also directly damage hemoglobin molecules, which are the oxygen-carrying proteins in red blood cells. These damaged proteins precipitate inside the cell and are called Heinz bodies. The spleen macrophages, that are responsible for eating up old or abnormal red blood cells, notice these Heinz bodies and try to remove them by taking a bite out of the cell, leaving these red blood cells partially devoured, so we call them bite cells. Now, the good news is that only older red blood cells are at risk for lysis, and the hemolytic episode is self-limited, as hemolysis stops when only younger red blood cells remain. So when a red blood cell dies, its hemoglobin breaks up into globin and heme. Heme is converted into bilirubin, which is then taken up by the liver cells and eventually secreted out with bile. If all of a sudden your body starts breaking down more red blood cells than the liver cells can handle, the excess bilirubin stays in the blood and causes jaundice, where the bilirubin deposits in the skin and the eyes, causing them to turn yellow. Some of the bilirubin is converted to urobilin, which is what gives urine that yellow color. If there's too much of it, the urine becomes a much darker tea-like color. This could overwhelm the kidneys, resulting in kidney damage. Okay, so there's a long list of things that could increase free radical production, and when there are too many free radicals for the body to handle, it's called oxidative stress, which leads to hemolytic episodes. These include infections like viral hepatitis or pneumonia, metabolic acidosis, and foods and drinks like fava beans, soy products, red wine, and others. Also, certain medications can act as oxidant stressors, like primaquine and chloroquine, which are ironically used to treat malaria. Other common drugs include painkillers like aspirin and ibuprofen, quinidine that's used to treat arrhythmias, and other drugs that contain sulfonamide like the antibiotic trimethoprim. Okay, now most of the patients with G6PD deficiency are completely asymptomatic until exposed to an oxidative stressor. Symptoms of acute hemolysis include jaundice, dark tea-colored urine, back pain due to kidney damage, and anemic symptoms like fatigue, hypotension, tachycardia, confusion, and others. The diagnosis can be suspected if there's a history of recent exposure to an oxidant, like starting a new medication or eating a fava bean pita followed by a hemolytic episode. Blood tests will show findings of hemolytic anemia, like low levels of red blood cells and increased levels of reticulocytes, which are immature red blood cells made by the bone marrow in an attempt to keep up with the red blood cell loss. Also, there will be high levels of lactate dehydrogenase, or LDH, which is an intracellular enzyme released in the blood. Next, there's high bilirubin and low haptoglobin, which is a molecule that binds free hemoglobin in the blood. Also, the Coombs test that is used to detect immune-mediated anemias will be negative. Now, the blood smear will show bite cells and Heinz bodies that are characteristic of G6PD deficiency and can be visualized with a special Heinz stain as dark intracellular inclusions within the red blood cells. But the definitive test for G6PD diagnosis is an enzyme assay to detect the levels of G6PD. Given the high risk of hemolysis, it's important to diagnose G6PD deficiency as early as possible, so newborns in many developed countries are tested a few days after birth. Now, because G6PD deficiency is a genetic condition, there's no known cure other than avoiding known triggers. Treatment during a hemolytic episode include hydration and blood transfusion that might be needed depending on the severity of the hemolysis. Alright, as a quick recap, G6PD deficiency is an X-linked recessive disorder, and it's characterized by low levels of glucose 6-phosphate dehydrogenase. In G6PD deficiency, red blood cells are susceptible to oxidative stress, which results in hemolysis. This is usually in response to certain triggers, like infections, foods like fava beans, and medications like sulfa drugs and antimalarials. Symptoms include jaundice, dark urine, back pain, and anemia. Typical findings on the blood smear are Heinz bodies and bite cells. Diagnosis can be confirmed with an enzyme assay. The mainstay of treatment is to avoid oxidant factors, but a transfusion might be needed if the hemolysis is severe.
Sickle cell disease, also called sickle cell anemia or just sickle cell, is a genetic disease where red blood cells can take the shape of a crescent or sickle, and that change allows them to more easily be destroyed, causing anemia, among other things. Sickle cell disease is caused by defective hemoglobin, which is the oxygen-carrying protein in red blood cells. Hemoglobin is actually made up of 4 peptide chains, each bound to a heme group. Different hemoglobins have different combinations of these chains. Hemoglobin A, or HbA, is made up of 2 alpha globin and 2 beta globin peptide chains. And this is the primary hemoglobin affected in sickle cell. Specifically, the beta globin chains end up misshapen. This is because of a mutation in the beta globin gene, or HBB gene. Sickle cell is an autosomal recessive disease, so a mutation in both copies of the beta globin gene is needed to get the disease. If the person has just one copy of the mutation and one normal HBB gene, then they're a sickle cell carrier, also called sickle trait. Having sickle trait does not cause health problems unless the person is exposed to extreme conditions, like high altitude or dehydration, where some sickle cell disease-like symptoms can crop up. What it does do is decrease the severity of infection by Plasmodium falciparum malaria. So in parts of the world with a high malaria burden, like Africa and pockets of southern Asia, those with sickle trait actually have an evolutionary advantage. This phenomenon is called heterozygote advantage, and its unfortunate consequence is a high rate of sickle cell disease in people from these parts of the world. Almost always, the sickle cell mutation is a non-conservative missense mutation that happens in the 6th amino acid of beta globin being a valine instead of glutamic acid. A non-conservative substitution means that the new amino acid, or valine, which is hydrophobic, has different properties than the one it replaced, glutamic acid, which was hydrophilic. A hemoglobin tetramer with 2 alpha globin and 2 mutated beta globin proteins is called sickle hemoglobin, or HbS. HbS carries oxygen perfectly well, but when deoxygenated, HbS changes its shape, which allows it to aggregate with other HbS proteins and form long polymers that distort the red blood cell into a crescent shape, a process called sickling. Conditions favorable for sickling include acidosis, which decreases hemoglobin's affinity for oxygen, and small, low-flow vessels where red blood cells' hemoglobin molecules have plenty of time to dump lots of oxygen molecules. Repeated sickling of red blood cells damages their cell membranes and promotes premature destruction. Since this happens within the vasculature, it's called intravascular hemolysis. This destruction of red blood cells not only leads to anemia, which is a deficiency in red blood cells or loss of the normal levels of hemoglobin, but also means a lot of hemoglobin spilling out. Free hemoglobin in the plasma is bound by a molecule called haptoglobin and gets recycled, which is why a low haptoglobin level is a sign of intravascular hemolysis. Recycling of that heme group yields unconjugated bilirubin, which at high concentration can cause scleral icterus, jaundice, and bilirubin gallstones. To counteract the anemia of sickle cell disease, the bone marrow makes increased numbers of reticulocytes, which are immature red blood cells. This ends up causing new bone formation, and the medullary cavities of the skull can expand outward, which causes enlarged cheeks and a hair-on-end appearance on skull X-ray. Extramedullary hematopoiesis, which is red blood cell production outside of the bone marrow, can also happen, most often in the liver, which can cause hepatomegaly. In sickled form, red blood cells tend to get stuck in capillaries, called vasoocclusion. Starting in infancy, they can clog up blood flow in the bones of the hands and the feet, causing dactylitis, or swelling and pain of the digits. Later, they get stuck in other bones, causing a sickle cell pain crisis, or avascular necrosis of the bone. Red blood cells can also clog up the spleen, which can lead to an infarct of the spleen as well as an enormous backup of blood in the spleen, called splenic sequestration, a life-threatening complication. Over time, splenic infarcts can lead to autosplenectomy, where the spleen scars down in fibrosis to basically nothing. Having an absent or non-functional spleen makes a person susceptible to encapsulated bacteria, like Streptococcus pneumoniae, Haemophilus influenzae, Neisseria meningitidis, and Salmonella species. Since encapsulated bacteria are normally opsonized and phagocytized by macrophages in the spleen. It also leaves a person with Howell-Jolly bodies, which are basophilic nuclear remnants in red blood cells, which can be seen on a peripheral blood smear. Sickled red blood cells can get stuck in the cerebral vasculature, causing vessel damage resulting in strokes. Extensive sickle cell damage to the brain vessels may result in moya-moya disease. which is named for the puff of smoke collateral vessels that bypass blocked arteries. They can also get stuck in the blood vessels of the lungs, leading to acute chest syndrome. This is particularly dangerous because it sets up a vicious cycle of congested, deoxygenated red blood cells preventing other red blood cells from getting oxygen. And this is made worse by the lung's natural tendency for hypoxic vasoconstriction, which is blood vessel constriction in areas of the lungs that are low in oxygen. In addition, clogging in the renal papillae can cause necrosis, which can manifest as hematuria and proteinuria, blood and protein spilling out into the urine. And in men, clogging of the vasculature of the penis can cause priapism, a painful and prolonged erection. Given all of these symptoms, it's important to diagnose sickle cell as early as possible, so it's included in the newborn blood spot screen in some countries. It can also be identified with a blood smear looking for sickled cells or by identifying HBS using protein electrophoresis. The factors that cause red blood cells to sickle, which are hypoxia, dehydration, and/or acidosis, can be improved with oxygen and fluids, which are mainstays of treatment. In addition, opioids are usually used to manage pain, and antibiotics are used to treat any underlying bacterial infections causing acute chest syndrome. Occasionally, blood transfusions are also used, but the risk of multiple transfusions include iron overload and the risk of developing new antibodies against future blood transfusions. Finally, children with sickle cell typically get prophylaxis with penicillin and an additional polysaccharide vaccine against Streptococcus pneumoniae to help prevent sepsis and meningitis with encapsulated bacteria. Another preventative medicine is hydroxyurea, which works by increasing the amount of gamma globin, which results in more fetal hemoglobin, or HbF. Fetal hemoglobin is made up of 2 alpha and 2 gamma globin chains, so it does not include the mutated beta globins. Since it cannot polymerize, it gets in the way of HbS polymers being made and prevents sickling. HbF is the primary hemoglobin at birth, which explains why sickle cell symptoms don't happen until a few months of life, when adult hemoglobin starts to predominate, which contains the mutated beta globin. More rarely, bone marrow transplants have been used in some patients, and given that sickle cell involves a single point mutation, gene therapy is another option being researched. Alright, as a quick recap, sickle cell disease is an autosomal recessive genetic disease where the beta globin subunit of hemoglobin is misshapen, which causes red blood cells to sickle when deoxygenated, and this leads to their premature destruction as well as vaso-occlusion. Furthermore, multi-organ damage is the end result from ongoing sickling and hypoxic damage to the body's important organs, resulting in a shortened lifespan.
Folate deficiency is a clinical condition that occurs because of a low level of folate or folic acid in the body. This can lead to a variety of problems ranging from anemia in individuals from all age groups to neural tube malformation in fetuses. Folate, also known as vitamin B9, mainly comes from eating leafy greens and citrus fruits like oranges and lemons. And nowadays, most countries fortify foods like grains and cereals with folate. Now, folic acid present in these food items is generally in polyglutamate form, which are basically chains of an amino acid called glutamic acid. Because of these carboxyl groups present in its structure, the chain is negatively charged, making it polar and soluble in water, which is a polar molecule, but not soluble in lipids, which are nonpolar molecules. So, the polyglutamate residues of folic acid are almost non-absorbable from the GI tract, where all the cells are surfaced with lipid cell membranes. So, to make them absorbable, when polyglutamate residues reach a portion of the small intestine called the jejunum, special enzymes present at the jejunal mucosa cut down the polyglutamate residues into monoglutamate. Monoglutamate is smaller and less negatively charged, so these monoglutamate residues of folic acids can pass through the cell membrane and enter the jejunal cells, where they're converted into tetrahydrofolic acid, or in short, THF, by the enzyme tetrahydrofolate reductase. These THFs then get methylated into a more stable form called methyl THF. Once formed, the methyl THF then leaves the jejunal cell and enters the bloodstream. Some of it goes to the liver and gets stored for a short period of 2 to 3 months, while most of it is used up for metabolic activity inside various cells around the body. Folic acid is used to synthesize DNA precursors, which is essential for DNA replication and cell division. On target cells, there's a specialized membrane protein called folic acid transporter, or FAT, which moves the circulating methyl THF inside the cell. Once inside, methyl THF transfers its methyl group to vitamin B12, ultimately making methylcobalamin and free THF in the process. THF then gets an extra methylene group from serine, an amino acid found within the cells. THF quickly transfers the methylene to a nucleotide called deoxyuridine monophosphate, or DUMP for short. As a result, DUMP becomes DTMP, or deoxythymidine monophosphate, which can then be converted to thymidine, one of the nucleotides used to build DNA. Going back, the methylcobalamin that was formed along with THF transfers its methyl group to homocysteine and converts it into an essential amino acid called methionine, thus lowering the levels of homocysteine in the body, too much of which can be harmful. Besides this, folic acid also plays a very important role during fetal development. Specifically, it's needed for the closure of the anterior neuropore of the neural tube during the 23rd day and the posterior neuropore during the 26th day of gestation. This is a crucial step in the development of the central nervous system. So, in short, the consequences of folic acid deficiency are impaired cell division, too much homocysteine in the body, and neural tube defects in fetuses. When cell division grinds to a halt, rapidly dividing cells in the bone marrow, such as red and white blood cells, as well as platelet precursors, are affected. Inside the bone marrow, red blood cell precursors are normally big and plump, and they undergo a series of cell divisions which results in smaller, mature red blood cells. Now, with folate deficiency, at first, the bone marrow pumps out larger but still mature red blood cells called macrocytes. These red blood cells are destroyed in the spleen, which causes a decrease in the total red blood cell count, or anemia. In response, the bone marrow compensates by releasing megaloblasts, which are abnormally developed red blood cell precursors, into the blood, and the final result is macrocytic megaloblastic anemia. Folate deficiency also affects white blood cell production. So the bone marrow starts releasing large immature neutrophils. Immature neutrophils are also hypersegmented, which means their nuclei have 6 or more lobes. Finally, severe folate deficiency may also decrease bone marrow production of platelet precursors, which are called megakaryocytes. So, when all 3 blood cell lines are affected, this results in pancytopenia, which is when red blood cell, white blood cell, and platelet count is low, and this happens only in cases of severe folate deficiencies. Other rapidly dividing cells are mucosal epithelial cells, especially those of the tongue mucosa. Have you ever noticed how fast your tongue heals if you accidentally bite it? That's because old epithelial cells are replaced with new ones in the blink of an eye. Okay, not literally that fast, but it's pretty quick. In folate deficiency, old epithelial cells aren't replaced, and this slows down the healing of normal wear and tear of the tongue, which ultimately leads to inflammation of the tongue, known as glossitis. Next, when homocysteine builds up in the body, some of it is excreted in the urine, leading to homocystinuria. It also builds up in the blood, where it binds to the endothelial cells lining blood vessels, causing them to secrete molecules called pro-inflammatory cytokines. These attract immune cells like leukocytes to the area and cause inflammation, which leads to atherosclerosis, or plaque buildup inside the arteries. This narrows the arteries and could lead to ischemia of the tissue supplied by them. Homocysteine also binds to platelets and makes them stick together to make blood clots. All of this increases the risk of ischemic heart disease and stroke. Lastly, when pregnant women suffer from folate deficiency around the time of conception, embryos may not properly develop the neural tube due to impairment in the closure of anterior and posterior neuropore of the neural tube, which may lead to neural tube defects. So, when the anterior neuropore doesn't close properly, the baby may be born with anencephaly, or absence of a major portion of the brain and the skull. Similarly, if the posterior neuropore doesn't close well, the baby may be born with spina bifida, or incomplete closure of the vertebrae and membranes of the spinal cord. Okay, now folate deficiency can result because of increased demand, decreased dietary intake, or impaired absorption. Normally, we have up to 2 to 3 months supply of folate in the body, but this can get used up even quicker during pregnancy due to the increased need for it. So generally, people who get folate deficiency are either pregnant or have had an extremely restricted diet for longer than 6 weeks. Besides this, excessive alcohol consumption and medications like phenytoin, trimethoprim, sulfasalazine, and methotrexate often interfere with folic acid absorption from the jejunum. Folate deficiency most commonly causes signs and symptoms of anemia, like shortness of breath, pallor, and easy fatigability, as well as soreness of the tongue due to glossitis. In some cases, they may also present with signs and symptoms of ischemic heart disease, like chest pain, or signs of stroke, like slurred speech and paralysis. Lastly, long-standing cases of severe folate deficiency may also present with features of pancytopenia like anemia due to low red blood cell count, recurrent infections due to low white blood cell count, and bleeding tendencies due to low platelet count. Diagnosis of folate deficiency relies on a peripheral blood smear, which shows large red blood cells. On a blood sample, a mean corpuscular volume, or MCV, larger than 100 femtoliters suggests macrocytosis. Homocysteine level is also elevated. A bone marrow study can also be done to look for the megaloblastic changes in red blood cell precursors at various stages of differentiation. After confirming that there is folate deficiency, the cause should be found. First, low dietary intake should be ruled out, and a pregnancy test should be done. Then, the history can help identify other causes, like medications or excessive alcohol consumption. When the cause of folate deficiency is dietary, it's treated with oral folate supplements. When the problem is absorption-related, it has to be managed by stopping the offending medications or limiting alcohol consumption. Lastly, in pregnant people, folate deficiency can be avoided by providing folate supplements or fortifying foods like grain and cereals with folate. Alright, as a quick recap. Folate deficiency is a clinical condition caused by low levels of folate in the body, which impairs cell division and causes excess levels of homocysteine in the body. This can lead to neural tube defects in fetuses, macrocytic megaloblastic anemia causing pallor, fatigability, and shortness of breath, glossitis or inflammation of the tongue leading to swelling and soreness, and difficulty in talking and swallowing. Diagnosis of folate deficiency can be made by doing a peripheral blood smear, measuring the MCV and serum levels of vitamin folate, as well as serum homocysteine levels. Folate deficiency is treated with folate supplements, folate-fortified food items, by stopping the offending medications, or limiting alcohol consumption. Vitamin B12 deficiency refers to low levels of vitamin B12 in the body. This can lead to a variety of problems ranging from anemia to soreness of the tongue and neurological dysfunction. Vitamin B12, also known as cobalamin, is a complex organometallic compound found in animal and dairy products like meat, eggs, or milk. Dairy and animal products are broken down in the stomach by pepsin, which is the active form of a gastric enzyme called pepsinogen to release B12. Then, a protein made by parietal cells in the stomach called intrinsic factor can bind to B12, and the B12 intrinsic factor complex passes into the intestines. When the complex reaches the terminal ileum, the enterocytes, which are the special cells lining the intestines, recognize intrinsic factor and absorb the whole complex. Inside the enterocytes, intrinsic factor gets removed and a special protein called transcobalamin 2 binds the free B12 and transports it into the blood, and from there to various target tissues. Some of the transcobalamin B12 complex gets to the liver, where B12 can be stored for several years. B12 is used to synthesize DNA precursors, which is essential for cell division. First, vitamin B12 accepts a methyl group for methyl tetrahydrofolate, or methyl THF, making methylcobalamin and free tetrahydrofolate, or THF, in the process. THF then gets an extra methylene group from serine, an amino acid found within the cells. THF quickly transfers the methylene to a nucleotide called deoxyuridine monophosphate, or DUMP for short. As a result, DUMP becomes DTMP, or deoxythymidine monophosphate, which can then be converted to thymidine, one of the nucleotides used to build DNA. Going back, the methylcobalamin that was formed along with the THF transfers its methyl group to homocysteine and converts it into an essential amino acid called methionine, thus lowering the levels of homocysteine in the body, too much of which can be harmful. Alternatively, B12 can be used by the mitochondria in another active form called adenosylcobalamin, which is basically B12 with an adenylyl group clinging to it. Adenylcobalamin acts as a coenzyme for methylmalonyl coenzyme A mutase, an enzyme which converts methylmalonyl coenzyme A into succinyl coenzyme A. This helps reduce the levels of methylmalonic acid, which can also be harmful if it builds up. So, in short, the consequences of B12 deficiency are that cell division is impaired and there's too much homocysteine and methylmalonic acid in the body. When cell division grinds to a halt, rapidly dividing cells in the bone marrow are affected, like red and white blood cells, as well as platelet precursors. Inside the bone marrow, red blood cell precursors are normally big and plump, and they undergo a series of cell divisions which results in smaller, mature red blood cells. Now, with B12 deficiency, at first, the bone marrow pumps out larger but still mature red blood cells called macrocytes. These red blood cells are destroyed in the spleen, which causes a decrease in the total red blood cell count, or anemia. In response, the bone marrow compensates by releasing abnormally developed red blood cell precursors, called megaloblasts, into the blood, and the final result is macrocytic megaloblastic anemia. B12 deficiency also affects white blood cell production, so the bone marrow starts releasing large, immature neutrophils with hypersegmented nuclei, meaning their nucleus has more than 5 lobes. Finally, severe B12 deficiency may also decrease the production of megakaryocytes, which are the platelet precursors in the bone marrow. So, when all 3 blood cell lines are affected, this results in pancytopenia, which is when red blood cell, white blood cell, and platelet count is low. And folate deficiency also decreases white blood cell, red blood cell, and megakaryocyte production in the bone marrow, also resulting in pancytopenia. Other rapidly dividing cells are mucosal epithelial cells, especially those of the tongue mucosa. Have you ever noticed how fast your tongue heals if you accidentally bite it? That's because old epithelial cells are replaced with new ones in the blink of an eye. Okay, not literally that fast, but it's pretty quick. In B12 deficiency, old epithelial cells aren't replaced, and this slows down the healing of normal wear and tear of the tongue, which ultimately leads to inflammation of the tongue known as glossitis. Next, when homocysteine builds up in the body, some of it is excreted in the urine, leading to homocystinuria. It also builds up in the blood, where it binds to the endothelial cells lining blood vessels, causing them to secrete molecules called pro-inflammatory cytokines. These attract immune cells like leukocytes to the area and cause inflammation, which leads to atherosclerosis, or plaque buildup inside the arteries. This narrows the arteries and could lead to ischemia of the tissue supplied by them. Homocysteine also binds to platelets and makes them stick together to make blood clots. All of this increases the risk of ischemic heart disease and stroke. Lastly, when there's too much methylmalonic acid in the body, it builds up in the neurons, specifically in the myelin sheath, which degenerates. Myelin helps transmit electrical impulses from one neuron to another at a very high speed. So, with B12 deficiency, communication between neurons gets significantly slower, which leads to impairment of neurological and muscle function. Kind of like the difference between optic fiber and the old dial-up internet connections. Okay, now B12 deficiency can result either because of impaired absorption or decreased dietary intake. Impaired absorption can result from a number of causes. For example, in pernicious anemia, there's increased production of overzealous IgA antibodies against intrinsic factor, or the parietal cells. Either way, this interferes with intrinsic factor's ability to bind to B12. In Crohn's disease, the enterocytes in the terminal ileum are often damaged, so B12 can't bind to transcobalamin to get to the target tissues. In people that get a gastric bypass, the ingested food passes through the stomach quickly, so even if intrinsic factor is produced, it can't get to the food to bind B12. Besides these, infestation in the terminal ileum with Diphyllobothrium latum, also known as fish tapeworm, or bacterial overgrowth in the blind loop of the bowel can also reduce absorption, leading to vitamin B12 deficiency. Decreased dietary intake is seen in individuals who avoid all animal products, like longtime strict vegans who don't take B12 supplements. Now, B12 deficiency most commonly causes signs and symptoms of anemia, like pallor, shortness of breath, and easy fatigability, as well as soreness of the tongue due to glossitis. In some cases, they may also present with signs and symptoms of ischemic heart disease, like chest pain, or signs of stroke like slurred speech and paralysis. Lastly, in very severe cases, B12 deficiency may lead to impairment of neurological function, where individuals present with loss of memory function, decreased reflexes, and psychosis. Diagnosis of vitamin B12 deficiency relies on a peripheral blood smear, which shows large red blood cells and hypersegmented neutrophils. On a blood sample, a mean corpuscular volume, or MCV, larger than 100 femtoliters suggests macrocytosis. A bone marrow study can also be done to look for the megaloblastic changes in red blood cell precursors at various stages of differentiation. Homocysteine and methylmalonic acid levels are also elevated. Finally, vitamin B12 deficiency can be confirmed by low total vitamin B12 levels in the blood. After confirming that there is a B12 deficiency, the cause should be found. First, low dietary intake should be ruled out. Then, to pinpoint the cause of decreased absorption, one can look for anti-intrinsic factor antibodies for pernicious anemia, or carry out endoscopic or imaging studies in patients that might have Crohn's disease. When the cause of B12 deficiency is dietary, it's treated with oral B12 supplements. When the problem is absorption related, it could be treated with either really high oral B12 doses to allow for passive diffusion in the gut, or with intramuscular B12 injections for a couple of months, which can be followed with oral supplements if needed. Additionally, treatment of the underlying cause, when possible, should be started. Alright, as a quick recap. Vitamin B12 deficiency is a clinical condition caused by low levels of vitamin B12 in the body, which impairs cell division and causes excess levels of homocysteine and methylmalonic acid in the body. This can lead to macrocytic megaloblastic anemia, causing pallor, shortness of breath, and fatigability, glossitis or inflammation of the tongue leading to swelling and soreness, difficulty in talking and swallowing, and myelin damage resulting in changes in reflexes, poor muscle function, memory problems, and psychosis in some extreme cases. Diagnosis of B12 deficiency can be made by doing a peripheral blood smear, measuring the MCV and serum levels of vitamin B12, as well as serum homocysteine and methylmalonic acid levels. B12 deficiency is treated with, B12, either as oral supplements or intramuscular injection.
At the Family Medicine Center, there is a 60-year-old Indigenous American named Eastu who came to visit the doctor because of his progressive fatigue and difficulty in swallowing. Next to him, there is a mother from Greece with her child Thalia, who is 10 months old. Little Thalia appeared healthy at birth, but in the past 2 months, her mother noticed that her face was often pale, she's been less active, and there was a mass in her belly. Both Istu and Thalia are suffering from anemia, which is defined as lower than average levels of hemoglobin, typically below 13.5 grams per deciliter in adult men and below 12.0 grams per deciliter in adult women. For children, this level varies based on the age. Now, anemias can be broadly grouped into 3 categories based on mean corpuscular volume, or MCV, which reflects the volume of a red blood cell, or RBC. So microcytic anemia is where the MCV is lower than 80 femtoliters. Normocytic with an MCV between 80 and 100 femtoliters, and macrocytic with an MCV larger than 100 femtoliters. Now let's focus on the microcytic anemias. And the most common causes are iron deficiency anemia, lead poisoning, sideroblastic anemia, and thalassemias. Although microcytic anemia can also present in anemia of chronic disease, which is caused by inflammatory conditions like rheumatoid arthritis and systemic lupus erythematosus, or SLE, it's usually classified as normocytic anemia. Now, iron deficiency anemia, lead poisoning, and sideroblastic anemia are caused by defective heme synthesis, while thalassemias are caused by defective globin chains. Normally, RBCs are loaded with millions of copies of a protein called hemoglobin. Hemoglobin is actually made up of 4 peptide or globin chains, each bound to a heme group. Those 4 heme molecules have right in the middle iron, which binds to oxygen and allows it to move in our body. Okay, so let's look at iron deficiency anemia, which could be caused by decreased intake, decreased absorption, increased demand, or increased loss of iron. For your exams, it's important to know that the clues to help you identify this disorder are often based on the patient's history. The most common cause of iron deficiency is chronic blood loss. This includes women with heavy menstruation, or people with bleeding gastric ulcers, and most importantly, elderly males with colon cancer that can bleed. Another cause of iron deficiency is decreased absorption. The duodenal cells are normally responsible for the absorption of iron, which is present in 2 forms in our diet: the heme iron and the non-heme iron. The heme iron is in the ferrous or Fe2+ state and can be directly absorbed. But the non-heme iron is in the ferric or Fe3+ state and needs to be reduced to heme iron first before being absorbed. So the stomach's hydrochloric acid activates a group of enzymes in the duodenal cells, collectively called ferroreductase, which reduces Fe3+ to Fe2+. Okay, so decreased iron absorption can occur with inflammation and destruction of duodenal cells, like in inflammatory bowel disease or celiac disease, or with decreased stomach acid production, like after a gastrectomy, where a part of the stomach is removed. Next, malnutrition, which sometimes happens with infants and vegans, and increased iron demand, like during pregnancy, can also cause iron deficiency anemia. So whatever the cause, we end up with a decrease in the body's iron stores, leading to decreased heme synthesis. And normally, there's a low level of free erythrocyte protoporphyrin, or FEP, in red blood cells, since this is a precursor to heme. So when there's a defect in heme synthesis, these precursors build up, and it's a good indicator for iron deficiency. The peripheral blood smear shows RBCs that are microcytic, since there's not enough hemoglobin for a normal-sized RBC, and the bone marrow starts pumping out smaller cells. They are also hypochromic, since they contain less hemoglobin and look more pale. Okay, another important fact is that the red blood cell distribution width, or RDW, is high. This is because we get a mix of normal-sized cells from before the iron deficiency and newly produced microcytic cells. Okay, moving on. If someone is chronically exposed to lead, usually children ingesting lead-containing paint chips, or adults who inhale lead while working in mines or industry, they can get lead poisoning. Lead inhibits delta-aminolevulinic acid, or delta-ALA, dehydratase, and ferrochelatase, two important enzymes in the heme synthesis pathway. It's important to remember that lead also inhibits rRNA degradation, causing old rRNA to accumulate inside the RBCs, forming tiny aggregates that are dispersed throughout the cytoplasm, and this is referred to as stippling. Once again, this affects heme synthesis, so free erythrocyte protoporphyrin, or FEP, builds up. On a peripheral blood smear, these aggregates stain blue, so they are basophilic, and we call this basophilic stippling. Now, just like iron deficiency anemia, there's a decrease in hemoglobin synthesis, so we get microcytic and hypochromic RBCs. The RDW is high because we also get a mix of normal-sized cells produced before the lead poisoning and newly produced microcytic cells. Next up is sideroblastic anemia, where sidero means iron and refers to iron accumulation in the mitochondria, and blast refers to the nucleated precursors of RBCs called erythroblasts. Sideroblastic anemia can be genetic or acquired. X-linked defect in ALA synthase gene is a genetic cause. ALA synthase normally catalyzes the first reaction in the heme biosynthetic pathway, and a defect in this enzyme prevents iron from being incorporated into heme, and they build up in the mitochondria. The acquired causes include pyridoxine or vitamin B6 deficiency, since ALA synthase uses vitamin B6 as a cofactor. For your exams, vitamin B6 deficiency commonly occurs as a result of isoniazid, which binds and inactivates vitamin B6. Myelodysplastic syndrome is an acquired cause of sideroblastic anemia, where the blood-forming cells in the bone marrow do not mature normally and become dysplastic. It's important to know that this increases the risk of developing hematological malignancies like acute myeloid leukemia. Other acquired causes include chronic alcohol use, lead poisoning, vitamin B6 deficiency, copper deficiency, and drugs like isoniazid and chloramphenicol. Remember for your test that these are reversible causes. On a peripheral blood smear, we get microcytic, hypochromic RBCs, and basophilic stippling, so it's similar to lead poisoning. However, the specific test to use is the Prussian blue stain on a bone marrow biopsy specimen, which shows the iron-laden mitochondria forming a ring around the nucleus, giving the classic ringed sideroblast appearance. Finally, the RDW is high as we get a mix of normal-sized cells and newly produced microcytic cells. Okay, moving on to thalassemias, where there's a deficiency or absence in the production of the globin chains of hemoglobin. Hemoglobin A, or HbA, made up of 2 alpha-globin and 2 beta-globin peptide chains, makes up approximately 97% of the total hemoglobin in adults. Hemoglobin A2, or HbA2, which is made up of 2 alpha-globin and 2 delta-globin chains, makes up approximately 2.5% of total hemoglobin. Now, hemoglobin F, or HbF, made up of 2 alpha globin and 2 gamma globin peptide chains, is the primary hemoglobin of the fetus, but makes up less than 1% in adults. In alpha thalassemia, there is a mutation in the genes that code for alpha globin chains, while in beta thalassemia, there is a mutation in the genes that code for the beta globin chains. Now in alpha thalassemia minima, there's one defective alpha gene, usually causing no symptoms. In alpha thalassemia minor, there are 2 defective alpha genes, causing mild microcytic hypochromic anemia. This can either be caused by a cis deletion, where mutated genes are on the same chromosome, or a transdeletion, when the mutated genes are on 2 different chromosomes. Cis deletion variants are more prevalent in Asian populations, whereas transdeletion variants are more prevalent in African populations. If 3 alpha genes are defective, it is hemoglobin H disease, or HbH, with moderate to severe microcytic hyperchromic anemia. And if all 4 alpha genes are defective, it's called hemoglobin Bart's disease, or HB-Bart's, and the fetus usually dies in utero. Peripheral blood smear shows microcytic hypochromic RBCs. Now when beta globin chain is underproduced, we have beta thalassemia minor, which is usually asymptomatic. When beta globin chain is absent, this is called beta thalassemia major and causes severe microcytic hypochromic anemia, which is not lethal in utero as the fetal hemoglobin does not contain beta chains. So in beta thalassemia major, HbF is protective, and the disease becomes symptomatic only after 6 months when HbF declines. Now the absence of beta globin leads to hypoxia because there is fewer HbA to carry oxygen to organs and tissues. To compensate, these individuals rely on the bone marrow to produce more red blood cells. A high-yield fact is that if they get infected with parvovirus B19, this may suppress red blood cell production in the bone marrow, which can cause a life-threatening aplastic crisis. Important facts to remember for exams is that HbA2 is elevated in beta thalassemia, both minor and major, to compensate for the decreased synthesis of HbA. A hint the test makers could give is that the disease is more prevalent in the Mediterranean population. Peripheral blood smear in beta thalassemia major shows target cells, and sometimes increased anisopoikilocytosis, meaning variation in size and shape of RBCs. X-ray of the skull might demonstrate a crew cut or hair on end appearance due to bone marrow expansion. Now in all thalassemias, the RDW is normal, reflecting the uniformity of RBC small size. However, in beta thalassemia major, RDW can be high due to anisopoikilocytosis. Another key concept you'll need to know is that they are diagnosed via hemoglobin electrophoresis. In beta thalassemia minor, HbA2 is greater than 3.5%, while in beta thalassemia major, the increase in HbA2 is greater, along with an increase in HbF. Now some individuals are HbS beta thalassemia heterozygotes. What this means is that they have one beta globin gene with the sickle cell disease mutation, which encodes for an abnormal adult hemoglobin called hemoglobin S for sickle, or HbS, and one with a beta thalassemia mutation. Depending on the type of beta thalassemia mutation, people may have no normal hemoglobin, called sickle beta 0 thalassemia, or a reduced amount of normal hemoglobin, called sickle beta plus thalassemia. In any case, when there's acidosis, hypoxia, or dehydration, HbS changes its shape and aggregates with other HbS proteins to form long chains that distort the RBC into a crescent shape that looks like a sickle. Sickled RBCs get stuck in capillaries, and that leads to tissue ischemia and pain. Oftentimes, it's an emergency called sickle cell crisis or vaso-occlusive crisis. Peripheral blood smear will reveal sickle-shaped cells, but diagnosis is made via hemoglobin electrophoresis. In a newborn with sickle beta 0 thalassemia, it will show an intense band of hemoglobin F or HbF and another lighter band of HbS, instead of the adult hemoglobin A or HbA. A newborn with sickle beta plus thalassemia will have an HbF as well as an HbS and a light HbA band. If newborn screening is not done, then the diagnosis is made during a sickle cell crisis. In this case, a healthy individual would have an intense band of HbA, an individual with sickle beta 0 thalassemia would have an intense band of HbS, and an individual with sickle beta plus thalassemia would have an HbS band with a light HbA band. Also, it's important to note that for clinical purposes, all the phenotypes of both alpha and beta thalassemias fall into two categories based on the dependency on blood transfusion for survival. First, there is transfusion-dependent thalassemia, or TDT, which covers all the subtypes that require regular blood transfusions for survival. This category includes beta thalassemia major, symptomatic beta thalassemia intermedia, severe HbH disease, and surviving HB Bart's hydrops fetalis. On the other hand, the non-transfusion-dependent thalassemia, or NTDT, refers to the thalassemias that do not require regular blood transfusions. This category includes beta thalassemia intermedia and non-severe HbH disease. Now, all anemias can present with fatigue, pallor, and shortness of breath, but other symptoms can help you identify the specific disease. For iron deficiency anemia, there's koilonychia, or spoon nail, where the nails become flat or even concave. Next is pica, which is the consumption of non-food substances like ice, hair, or dirt, and glossitis. Plummer-Vinson syndrome is also associated with iron deficiency and presents with chylosis and dysphagia due to esophageal webs. Lead poisoning can present with abdominal pain or colic, constipation, and in severe cases with neurologic signs due to encephalopathy. Wrist and foot drop due to peripheral neuropathy can also occur, and patients can also have blue lead lines or bluish pigmentation at the junction of the teeth and gingiva. Now, in beta thalassemia major, patients can have skeletal deformities caused by bone marrow expansion. This leads to chipmunk facies, meaning enlarged forehead and cheeks. Now, the body will also undergo extramedullary hematopoiesis, where the liver and spleen will try to produce extra red blood cells, and this can cause hepatosplenomegaly. HbS beta thalassemia heterozygotes have mild to moderate sickle cell disease symptoms. These include acute complications like sickle cell crises, causing a variety of problems like avascular bone necrosis, stroke, acute chest syndrome, renal dysfunction, and priapism. Another acute complication is splenic sequestration. Chronic complications include growth and developmental delay, learning and behavior issues, pulmonary hypertension, and chronic kidney disease. Now, it's important to remember the iron studies values, since they might be the best clues for identifying the cause of a microcytic anemia. Iron studies include serum iron, ferritin, a marker of iron stores, transferrin, a molecule that transports iron in the blood, and TIBC, total iron binding capacity, which indicates the amount of unbound transferrin in the blood. Now, in iron deficiency, there's low serum iron, so there's nothing to store meaning low ferritin. Now remember that ferritin is an acute phase reactant, so it could be elevated during infections and chronic illnesses. The liver makes more transferrin since the body wants to shuttle as much of the available iron as possible, and since there's so little iron, the TIBC is increased. In sideroblastic anemia, there's plenty of iron, but it can't be used to make heme. So there's high serum iron, high ferritin, but normal or low transferrin, and TIBC. In thalassemias, there's high serum iron, high ferritin, and low transferrin and TIBC. Iron overload occurs in thalassemias due to ineffective erythropoiesis and from the multiple blood transfusions used to treat the disorder. In lead poisoning, iron studies are normal. Alright, now treatment for iron deficiency anemia includes addressing the cause and giving oral iron supplements. For lead poisoning, first-line treatments include chelating agents, which trap free lead and sweep it away through feces or urine. These are dimercaprol and EDTA for adults and Succimer for children. For sideroblastic anemia, treatment involves removal of toxins if there are any, and administering pyridoxine. Finally, patients with mild thalassemia don't need treatment, while patients with severe thalassemia are treated with blood transfusions. Alright, as a quick recap, microcytic anemias can occur when there's a problem in synthesizing one of the two main components of hemoglobin, heme and the globin chains. There are many disorders that affect heme synthesis, and iron deficiency anemia is the most common. Sideroblastic anemia and lead poisoning also fall under this category. Thalassemia, on the other hand, affects globin chain synthesis and could be alpha or beta depending on which type of globin chain is affected. A diagnosis can be made based on iron studies and electrophoresis, but also consider the other symptoms and lab findings. Now back to the patients. Due to his age, IS-2 most likely has iron deficiency anemia due to colon cancer. He also has Plummer-Vinson syndrome, which is causing his dysphagia. This can be confirmed with iron studies, and it's important to order a colonoscopy to check for colorectal carcinoma. Meanwhile, Talia probably has beta thalassemia, as symptoms started 6 months after birth due to the decline in HbF. Another hint is that this disorder is more prevalent in the Mediterranean population, like the Greeks. The mass in her belly is due to hepatosplenomegaly, and a hemoglobin electrophoresis will confirm the diagnosis.
Alpha thalassemia is a genetic disorder where there's a deficiency in the production of the alpha globin chains of hemoglobin, which is the oxygen-carrying protein in red blood cells. Normally, hemoglobin is made up of 4 globin chains, each bound to a heme group. There are 4 major types of globin chains: alpha, beta, gamma, and delta. These 4 globin chains combine in different ways to give rise to different kinds of hemoglobin. First, there's hemoglobin F, or HbF, where F stands for fetal hemoglobin, and it's made of 2 alpha globin and 2 gamma globin chains. Hemoglobin A, or HbA, is the major form of adult hemoglobin, and it's made of 2 alpha globin and 2 beta globin chains. Finally, hemoglobin A2, or HbA2, amounts for a small fraction of adult hemoglobin in the blood, and it's made of 2 alpha globin and 2 delta globin chains. Alpha chain synthesis is controlled by 4 alpha genes, 2 on each copy of chromosome 16. And alpha thalassemia is caused by mutations in the alpha genes, most commonly a gene deletion. The mutations are inherited in an autosomal recessive pattern, which means that you need mutated genes from both parents to get the disease. If a person has one defective alpha gene, They're called a silent carrier because they don't have symptoms, but they can still pass the gene on to their children. If a person has 2 defective alpha genes, the person has alpha thalassemia minor, which causes mild symptoms. This can either be caused by a cis deletion, where mutated genes are on the same chromosome, or a trans deletion, when the mutated genes are on 2 different chromosomes. Cis deletion variants are more prevalent in Asian populations, whereas trans deletion variants are more prevalent in African populations. If there are 3 defective alpha genes, there's moderate disease, called hemoglobin H, or HbH disease. This is caused by excess beta chains, which clump together within developing red blood cells to form tetramers, or beta 4, and give rise to a form of hemoglobin called hemoglobin H. HbH molecules cause hypoxia in 2 ways. First, they damage the red blood cell membrane, resulting in intramedullary hemolysis, or red blood cell breakdown in the bone marrow, or extravascular hemolysis, when red blood cells are destroyed by macrophages in the spleen. Second, HbH has a very high affinity for oxygen and doesn't release oxygen to the tissues. And a consequence of hypoxia is that it signals the bone marrow, as well as extramedullary tissues like the liver and spleen, to increase production of red blood cells. This can cause the bones that contain bone marrow, as well as the liver and the spleen, to enlarge. Finally, if all 4 alpha genes are deleted, it results in HB Bart's hydrops fetalis. The problem here begins during fetal life, where gamma chains form tetramers in the absence of alpha chains, called HB Bart's gamma 4. And it has super duper high affinity for oxygen, about 100 times that of normal hemoglobin. So, the tissues get no oxygen, resulting in severe hypoxia. Severe hypoxia leads to high output cardiac failure and massive hepatosplenomegaly, resulting in edema all over the body, called hydrops fetalis. This condition is incompatible with life, and without treatment, the fetus usually dies in utero or soon after birth. The initial symptoms of minor and moderate alpha thalassemia are due to anemia, which include pallor, shortness of breath, and easy fatigability. There can also be skeletal deformities and hepatosplenomegaly. Diagnosis starts with a routine blood test that shows low hemoglobin levels, decreased mean corpuscular volume, or MCV, and low mean corpuscular hemoglobin, or MCH. The peripheral blood smear shows microcytic, or small, and hypochromic, or pale, red blood cells. There are also target cells, which are small red blood cells that look like bullseyes due to scrunching up of excess cell membrane. With moderate alpha thalassemia, there may be golf ball-like red blood cells due to precipitated HbH molecules. Hemoglobin electrophoresis can be done to see which hemoglobin types are present. For example, HbH will be seen as an extra band ahead of HbA on electrophoresis. Finally, the diagnosis is confirmed by genetic testing to look for hemoglobin gene mutations. This can also be done prenatally by testing fetal DNA obtained through either chorionic villus sampling or amniocentesis.
Usually, patients with mild alpha thalassemia don't need treatment, while patients with severe thalassemia are treated with blood transfusions. Based on the requirement for transfusion or not, all alpha thalassemia subtypes can be grouped into 2 clinically relevant categories. These are transfusion-dependent thalassemias and non-transfusion-dependent. Transfusion-dependent thalassemias involve all the subtypes in which recurrent blood transfusions are needed for survival, like surviving HB Bart's hydrops fetalis and severe forms of HbH disease. On the other hand, non-transfusion-dependent thalassemias refers to the thalassemias that do not require regular blood transfusions for survival, such as alpha thalassemia intermedia involving most HbH disease cases. It is important to note that for the prevention of transfusion-related iron overload, iron chelating agents may be given to trap some excess iron and sweep it away through feces or urine. When diagnosed prenatally, HB Bart's hydrops fetalis can be treated with intrauterine transfusions and later followed up with bone marrow transplantation.
Alright, as a quick recap, Alpha thalassemia is an autosomal recessive disorder caused by deletion of alpha globin genes on chromosome 16. Single gene defect results in a silent carrier state, which is asymptomatic. 2 defective genes results in alpha thalassemia minor, which causes mild anemia. 3 defective genes causes HBH disease, which causes severe anemia with hepatosplenomegaly. And 4 defective genes results in HB Bart's hydrops fetalis, which is incompatible with life, and without treatment, the fetus usually dies in utero or soon after birth.
Anemia of chronic disease refers to a low red blood cell, or RBC, that may be associated with many chronic disease states like infections, malignancy, diabetes, or autoimmune disorders. The disease used to be called anemia of chronic inflammation because the underlying cause of anemia is the continuous inflammation generated by chronic disease, which impairs iron metabolism and, in turn, RBC production. The anemia itself is usually mild, and it's the second most common type of iron deficiency anemia. RBCs are produced in the bone marrow in response to erythropoietin, which is a molecule secreted by the kidneys in response to low levels of oxygen in the blood. Taking a closer look at our RBCs, we can see they're loaded with millions of copies of the same exact protein called hemoglobin, which binds to oxygen and turns our RBCs into little oxygen transporters that move oxygen to all of the tissues in our body. Zooming in even closer, each hemoglobin molecule is made up of 4 smaller heme molecules, which have iron right in the middle. Oxygen binds to the iron, so each hemoglobin molecule can bind 4 molecules of oxygen. In addition, iron is also an important part of proteins like myoglobin, which delivers and stores oxygen in muscles, and mitochondrial enzymes like cytochrome oxidase, which help generate ATP.
Now, we get the iron required for RBC production from our diet. Following breakdown of food in the stomach, iron is released as Fe2+ ions, and then it's absorbed in the small intestine, specifically the duodenum. Inside the duodenal cells, an enzyme called hephaestin oxidizes iron 2+ to iron 3+ ions. This form of iron binds to a protein called ferritin, which temporarily stores the iron. When iron is needed in the body, some iron molecules are released from ferritin and transported into the blood, where they bind to an iron transport protein called transferrin that carries iron to various target tissues and releases them there.
Now, the mechanisms that underlie anemia of chronic disease are complex and still under investigation. In general, the disease mechanism is a twofold process: decreased RBC lifespan and decreased RBC production. Shortened RBC lifespan is a result of direct cellular destruction via toxins from cancer cells, viruses, or bacterial infections. Decreased RBC production is a bit more complex and involves several mechanisms. The most important one, and the one that most researchers agree upon, involves dysregulation of iron homeostasis and the signals that control RBC production. In chronic disease states, chemical messengers called cytokines mediate this pathologic process in the kidney, immune system, and the GI tract. 2 cytokines called tumor necrosis factor alpha and interferon gamma inhibit the production of erythropoietin in the kidney, which subsequently prevents RBC production in the bone marrow. Additionally, tumor necrosis factor alpha promotes RBC degradation in macrophages via phagocytosis, and interferon gamma increases the expression of a protein channel called divalent metal transporter 1 on the surface of macrophages. This channel serves as a pathway for iron to enter the macrophage at increased rates, so less iron is available for the production of hemoglobin. Another cytokine called IL-10 mediates the expression of increased ferritin receptors on the surface of macrophages, which then sequesters even more iron. Finally, IL-6 also works in the liver by increasing production of a molecule called hepcidin, which blocks further uptake of iron from the small intestine. The culmination of all these processes results in inadequate iron available for the production of hemoglobin. So with either being locked up in macrophages or unable to be absorbed, fully productive hemoglobin-laden RBCs cannot be produced. Symptoms of anemia of chronic disease are usually mild, including fatigue, pallor, and shortness of breath. And the latter is usually associated with physical activity, like walking up 3 flights of stairs. Anemia of chronic disease is usually discovered incidentally during the workup for a chronic disease process. A complete blood count usually shows mildly decreased hemoglobin, usually between 10 and 12 grams per deciliter. Initially, the anemia is normocytic, which means that RBCs have a normal size, but eventually it can become microcytic, meaning RBCs get smaller. Iron studies show low serum iron levels, normal to low serum iron transferrin or total iron binding capacity, low transferrin saturation, and normal or increased serum ferritin levels. Hepcidin levels are also usually elevated, although assays to detect hepcidin levels are not widely available. Bone marrow examination, while not routinely performed in the assessment of anemia of chronic disease, can demonstrate macrophages with increased iron stores and erythroid precursor cells. Treatment of anemia of chronic disease requires correcting the underlying problem or disease process. For example, if the anemia is due to an infection, appropriate treatment with antibiotics may be necessary. If a person has a tumor, surgical removal of the tumor may lead to resolution of the anemia. Similarly, if the anemia is due to diabetes, improved blood glucose control may result in an improvement in the anemia. Intravenous iron therapy can sometimes be useful, and when hemoglobin levels fall below 7 grams per deciliter, transfusions with packed RBCs or erythropoietic agents like epoetin alpha or darbepoetin alpha may be given to improve symptoms. All right, as a quick recap, anemia of chronic disease occurs in the context of chronic disease states like infections, malignancy, diabetes, and autoimmune conditions. The mechanism of disease is largely mediated by inflammatory factors, including hepcidin. Treatment involves correcting the underlying condition, or, in severe cases, RBC transfusions or erythropoietin injections. Anemia of chronic disease refers to a low red blood cell, or RBC, that may be associated with many chronic disease states like infections, malignancy, diabetes, or autoimmune disorders. The disease used to be called anemia of chronic inflammation because the underlying cause of anemia is the continuous inflammation generated by chronic disease, which impairs iron metabolism and, in turn, RBC production. The anemia itself is usually mild and is the second most common type of iron deficiency anemia. RBCs are produced in the bone marrow in response to erythropoietin, which is a molecule secreted by the kidneys in response to low levels of oxygen in the blood. Taking a closer look at our RBCs, we can see they're loaded with millions of copies of the same exact protein called hemoglobin, which binds to oxygen and turns our RBCs into little oxygen transporters that move oxygen to all of the tissues in our body. Zooming in even closer, each hemoglobin molecule is made up of 4 smaller heme molecules, which have iron right in the middle. Oxygen binds to the iron, so each hemoglobin molecule can bind 4 molecules of oxygen. In addition, iron is also an important part of proteins like myoglobin, which delivers and stores oxygen in muscles, and mitochondrial enzymes like cytochrome oxidase, which help generate ATP.
Now, we get the iron required for RBC production from our diet. Following breakdown of food in the stomach, iron is released as Fe2+ ions, and then it's absorbed in the small intestine, specifically the duodenum. Inside the duodenal cells, an enzyme called hephaestin oxidizes iron 2+ to iron 3+ ions. This form of iron binds to a protein called ferritin, which temporarily stores the iron. When iron is needed in the body, some iron molecules are released from ferritin and transported into the blood, where they bind to an iron transport protein called transferrin that carries iron to various target tissues and releases them there.
Now, The mechanisms that underlie anemia of chronic disease are complex and still under investigation. In general, the disease mechanism is a twofold process: decreased RBC lifespan and decreased RBC production. Shortened RBC lifespan is a result of direct cellular destruction via toxins from cancer cells, viruses, or bacterial infections. Decreased RBC production is a bit more complex and involves several mechanisms. The most important one, and the one that most researchers agree upon, involves dysregulation of iron homeostasis and the signals that control RBC production. In chronic disease states, chemical messengers called cytokines mediate this pathologic process in the kidney, immune system, and the GI tract. Two cytokines called tumor necrosis factor alpha and interferon gamma inhibit the production of erythropoietin in the kidney, which subsequently prevents RBC production in the bone marrow. Additionally, tumor necrosis factor alpha promotes RBC degradation in macrophages via phagocytosis, and interferon gamma increases the expression of a protein channel called divalent metal transporter 1 on the surface of macrophages. This channel serves as a pathway for iron to enter the macrophage at increased rates, so less iron is available for the production of hemoglobin. Another cytokine called IL-10 mediates the expression of increased ferritin receptors on the surface of macrophages, which then sequesters even more iron. Finally, IL-6 also works in the liver by increasing production of a molecule called hepcidin, which blocks further uptake of iron from the small intestine. The culmination of all these processes results in inadequate iron available for the production of hemoglobin. So with either being locked up in macrophages or unable to be absorbed, fully productive hemoglobin-laden RBCs cannot be produced. Symptoms of anemia of chronic disease are usually mild, including fatigue, pallor, and shortness of breath, and the latter is usually associated with physical activity, like walking up 3 flights of stairs. Anemia of chronic disease is usually discovered incidentally during the workup for a chronic disease process. A complete blood count usually shows mildly decreased hemoglobin, usually between 10 and 12 grams per deciliter. Initially, the anemia is normocytic, which means that RBCs have a normal size, but eventually it can become microcytic, meaning RBCs get smaller. Iron studies show low serum iron levels, normal to low serum iron transferrin or total iron binding capacity, low transferrin saturation, and normal or increased serum ferritin levels. Hepcidin levels are also usually elevated, although assays to detect hepcidin levels are not widely available. Bone marrow examination, while not routinely performed in the assessment of anemia of chronic disease, can demonstrate macrophages with increased iron stores and erythroid precursor cells. Treatment of anemia of chronic disease requires correcting the underlying problem or disease process. For example, if the anemia is due to an infection, appropriate treatment with antibiotics may be necessary. If a person has a tumor, surgical removal of the tumor may lead to resolution of the anemia. Similarly, if the anemia is due to diabetes, improved blood glucose control may result in an improvement in the anemia. Intravenous iron therapy can sometimes be useful, and when hemoglobin levels fall below 7 grams per deciliter, transfusions with packed RBCs or erythropoietic agents like epoetin alpha or darbepoetin alpha may be given to improve symptoms. All right, as a quick recap, anemia of chronic disease occurs in the context of chronic disease states like infections, malignancy, diabetes, and autoimmune conditions. The mechanism of disease is largely mediated by inflammatory factors, including hepcidin. Treatment involves correcting the underlying condition, or, in severe cases, RBC transfusions or erythropoietin injections.
Beta thalassemia is a genetic disorder where there's a deficiency in production of the beta-globin chains of hemoglobin, which are the oxygen-carrying proteins in red blood cells, or RBCs for short. Beta thalassemia is most commonly seen in Mediterranean, African, and Southeast Asian populations. Normally, hemoglobin is made up of 4 globin chains, each bound to a heme group. There are 4 major globin chain types: alpha, beta, gamma, and delta. These 4 globin chains combine in different ways to give rise to the different kinds of hemoglobin. First, there's hemoglobin F, or HbF, where F stands for fetal hemoglobin, and that's made up of 2 alpha globin and 2 gamma globin chains. Hemoglobin A, or HbA, the major adult hemoglobin form, is made up of 2 alpha globin and 2 beta globin chains. Finally, hemoglobin A2, or HbA2, accounts for a small fraction of adult hemoglobin in the blood, and it's made up of 2 alpha globin and 2 delta globin chains. With beta thalassemia, there's either a partial or complete beta globin chain deficiency due to a point mutation, which is when a single nucleotide in DNA is replaced by another nucleotide in the beta globin gene present on chromosome 11. And most often, these mutations occur in 2 regions of the gene called the promoter sequences and splice sites, which affects the way the mRNA is read. The result is either reduced or completely absent beta globin chain synthesis. And since this is an autosomal recessive disease, 2 mutated copies of this gene, one from each parent, are needed to develop the disease. If the person has just 1 mutated gene that codes for either a reduced production or absent production of beta globin chains, then they have beta thalassemia minor. If the person has 2 mutated genes that code for reduced beta globin chain synthesis, then they're said to have beta thalassemia intermedia. If the person has 2 beta 0 mutations, then no beta globin chains are produced, and they're said to have beta thalassemia major. When there's a beta globin chain deficiency, free alpha chains accumulate within red blood cells, and they clump together to form intracellular inclusions, which damage the red blood cell's cell membrane. This causes hemolysis, or red blood cell breakdown in the bone marrow, or extravascular hemolysis, where red blood cells are destroyed by macrophages in the spleen. Hemolysis causes hemoglobin to spill out directly into the plasma, where heme is recycled into iron and unconjugated bilirubin. Over time, the excess unconjugated bilirubin leads to jaundice, and excess iron deposits leads to secondary hemochromatosis. At the same time, hemolysis leads to hypoxia, because there are fewer red blood cells to carry oxygen to organs and tissues. And a consequence of hypoxia is that it signals the bone marrow and extramedullary tissues like the liver and spleen to increase red blood cell production, which may cause bone marrow-containing bones, like those in the skull and face, as well as the liver and spleen, to enlarge. Okay, now beta thalassemia minor is usually asymptomatic. On the other hand, with beta thalassemia major, symptoms do not develop until the first 3 to 6 months of life. That's because during the first 3 to 6 months of life, fetal hemoglobin is still produced, and that process uses up some of the free alpha chains. Common beta thalassemia major signs and symptoms include symptoms of anemia like pallor, shortness of breath, and easy fatigability, jaundice, swollen abdomen due to an enlarged liver and spleen, hepatosplenomegaly, and growth retardation. Complications due to hemochromatosis include arrhythmias, pericarditis, cirrhosis, hypothyroidism, and diabetes mellitus. Other beta thalassemia major findings may include enlarged forehead and cheekbones, which is called chipmunk facies. On a skull x-ray, the skull bones show a radiolucent bone marrow with fine hair-like projections that look a bit how the hair on your arm stand up when you get the goosebumps. So it's called hair-on-end appearance. Alternatively, this is also called a crew cut appearance, named after the type of haircut. Diagnosis of beta thalassemia usually begins with a routine blood test that shows a low hemoglobin level, decreased mean corpuscular volume, or MCV, and a high red blood cell distribution width, or RDW, which indicates that the red blood cells come in a lot of different sizes. However, the RDW is often normal with beta thalassemia minor. The peripheral blood smear shows microcytic or small and hypochromic or pale red blood cells. There are also target cells, which are small red blood cells that look like bullseyes due to scrunching up of the excess cell membrane. Lab work may also show high serum iron, high ferritin, and a high transferrin saturation level. Finally, the diagnosis is confirmed with hemoglobin electrophoresis, which shows low amounts of HbA, but an increase in HbF and HbA2 levels, which are formed when excess alpha chains start binding to gamma and delta chains. In beta thalassemia minor, there's usually an increased HbA2 level, greater than 3.5% on gel electrophoresis. Beta thalassemia does not always require treatment, but when needed, blood transfusions are given to correct low hemoglobin levels and associated symptoms. Based on the need for blood transfusion, there are two clinically relevant categories of beta thalassemia. First, there's the transfusion-dependent thalassemia category, which refers to all the phenotypes that require recurrent blood transfusions for survival. This category includes beta thalassemia major and sometimes intermediate beta thalassemia with severely reduced beta chain synthesis. The second category is that of non-transfusion-dependent thalassemia, which refers to thalassemias that do not require regular blood transfusions. This category includes beta thalassemia minor and beta thalassemia intermedia with milder symptoms. Keep in mind that regular blood transfusions add up to the iron overload, which can worsen hemochromatosis. To prevent this, iron chelating agents like deferoxamine are given, which trap some of the excess iron and sweep it away through feces or urine. Finally, a splenectomy can be done when splenomegaly causes excess hemolysis. Beta thalassemia is an autosomal recessive disorder caused by a mutation in the beta globin gene present on chromosome 11, which results in reduced or completely absent beta globin chain synthesis. There are three types: beta thalassemia minor, intermedia, and major. Beta thalassemia major causes chipmunk facies, hair on end appearance on a skull x-ray, hepatosplenomegaly, jaundice, and secondary hemochromatosis.
Iron deficiency anemia is a condition that occurs when the body lacks sufficient iron to produce enough healthy red blood cells. Iron plays a vital role in the production of hemoglobin, which is the protein responsible for carrying oxygen in red blood cells. So, when iron levels are low, the body is unable to produce an adequate amount of hemoglobin, leading to a decrease in red blood cell production and subsequent anemia. While history and physical examination findings can provide hints to iron deficiency anemia, confirming the diagnosis requires laboratory tests, primarily iron studies and a peripheral blood smear. Now, if your patient presents with a chief concern suggestive of iron deficiency anemia, first you should start with a focused history and physical examination. History typically reveals vague symptoms like fatigue and dizziness, as well as palpitations and dyspnea on exertion, which manifest as compensatory responses to inadequate tissue oxygen supply. Other symptoms may include pica, which is the compulsive consumption of non-nutritive substances like dirt or ice. Some patients may also develop Plummer-Vinson syndrome, which is characterized by the triad of iron deficiency anemia, esophageal webs, and dysphagia. Additionally, some patients with iron deficiency may experience restless leg syndrome. Be sure to assess your patient's nutritional history since they might have a diet deficient in iron-rich foods. For example, the patient might report that they seldom eat red meat, leafy greens, and fortified grains, which are all rich in iron. Next, your patient may have a history of gastrointestinal absorption problems that would prevent them from absorbing adequate dietary iron. These include inflammatory bowel disease, Helicobacter pylori infection, celiac disease, or a history of gastrointestinal surgery, such as bariatric surgery. There may also be a history of chronic blood loss, which could be caused by gastrointestinal bleeding, like in peptic ulcer disease or colon cancer, or by conditions like menorrhagia. Lastly, check if there are any increased iron requirements, which can be seen in conditions like pregnancy. Now, here's a clinical pearl. Certain medications can potentially result in iron deficiency anemia, such as nonsteroidal anti-inflammatory drugs, or NSAIDs, which can increase the risk of peptic ulcers and subsequent bleeding, and proton pump inhibitors, or PPIs, which can reduce absorption of iron. So if you notice your patient has been using these medications, this should increase your suspicion of iron deficiency anemia. Okay, now let's move on to the physical exam, which typically reveals tachycardia and tachypnea, which are compensatory responses to reduced tissue oxygen delivery, as well as signs of pallor such as pale conjunctiva, lips, and nail beds. Other common findings include brittle nails and koilonychia, characterized by nails that are concave or spoon-shaped. Additionally, you might notice a smooth and glossy tongue, as well as chylosis, which refers to inflammation and cracking at the corners of the mouth. At this point, you should suspect iron deficiency anemia. Your next step is to order labs such as a CBC, reticulocyte count, serum iron, and serum ferritin, as well as transferrin saturation, or TSAT, total iron binding capacity, or TIBC, and serum transferrin. Finally, don't forget to request a blood smear. Here's a high-yield fact to keep in mind. Hookworm infestations, such as Ancylostoma duodenale, can cause iron deficiency anemia. This occurs as hookworms cause damage to the gastrointestinal mucosa, leading to chronic gastrointestinal blood loss that over time results in anemia. So, when you suspect a hookworm infestation, order a stool analysis to confirm. Now, moving on to the lab results. The CBC typically reveals low red blood cell count with a low reticulocyte count, low mean corpuscular volume, or MCV, decreased mean corpuscular hemoglobin concentration, or MCH, increased red cell distribution width, or RDW, as well as reduced hemoglobin and hematocrit. Additionally, serum iron and ferritin levels are typically decreased, reflecting the reduced availability of iron in the blood. The TSAT, which is basically the percentage of occupied iron-binding sites on transferrin, is also reduced. On the other hand, the TIBC and serum transferrin levels are increased, reflecting an attempt by the body to capture any available iron as a compensatory measure. Lastly, check the peripheral blood smear for characteristic features of iron deficiency anemia. Typically, you will observe microcytic and hypochromic red blood cells, indicating reduced hemoglobin synthesis. There is also anisocytosis, which are red blood cells with varying sizes, as well as poikilocytosis, meaning that there's variation in the shape of red blood cells. All of these findings are highly suggestive of iron deficiency anemia, so at this point you can confirm the diagnosis. Now, a clinical pearl. Microcytic, hypochromic red blood cells and anisocytosis are not specific to iron deficiency anemia. They can also be seen in other conditions such as thalassemia and sideroblastic anemia. So don't rely on blood smear alone to diagnose iron deficiency. Remember to check iron studies as well. Alright. Now that you've diagnosed iron deficiency anemia, let's turn our attention to treatment. Managing iron deficiency anemia involves addressing the underlying cause and providing iron supplements. For example, treatment may involve incorporating iron-rich foods into the diet, managing chronic conditions like peptic ulcers, or deworming for intestinal hookworm infestations. Next, replenish the iron stores by giving iron supplementation. The first-line iron supplementation consists of oral iron therapy, such as ferrous sulfate. The duration of the treatment depends on the severity of the anemia and can last several months. For optimal iron absorption, you should advise your patients to take oral iron on an empty stomach. Now, if oral supplementation is ineffective, especially for those patients you are concerned about malabsorption, consider parenteral iron therapy. This involves administering parenteral iron formulations, either intravenously or intramuscularly, such as iron dextran. Parenteral iron therapy is typically reserved for severe iron deficiency anemia, cases of intolerance or noncompliance with oral iron, and malabsorption conditions or ongoing blood loss. Lastly, consider packed red blood cell transfusion for patients with severely symptomatic anemia. Here's one last clinical pearl. If an elderly patient presents with iron deficiency anemia and has no overt bleeding, the most likely source is occult gastrointestinal bleeding until proven otherwise, so they should get a colonoscopy to rule out colorectal cancer. Alright, as a quick recap, iron deficiency anemia occurs when the body lacks sufficient iron to produce enough hemoglobin for healthy red blood cells. While clinical presentation can raise suspicion, confirming the diagnosis requires specific lab tests, including CBC, reticulocyte count, serum iron, serum ferritin, TSAT, TIBC, and serum transferrin. In iron deficiency anemia, the CBC reveals low red blood cell count, low reticulocyte count, low MCV, low MCH, and high RDW. The hemoglobin and hematocrit will also be low. Serum iron and ferritin levels and TSAT are decreased, while TIBC and serum transferrin are increased. The peripheral blood smear shows microcytic hypochromic red blood cells with anisocytosis and poikilocytosis. Treatment involves addressing the underlying cause and providing iron supplementation. The first-line treatment includes oral iron, but if ineffective, consider second-line treatment with parenteral iron. Lastly, consider packed red blood cell transfusion for patients with severely symptomatic anemia.
Anemia is a condition where there's a decrease in the number of healthy red blood cells, or RBCs, in the body. So, iron deficiency anemia means anemia caused by a deficiency in iron. Iron deficiency anemia is the most common type of anemia worldwide. If we take a close look at our red blood cells, we'll notice that they're loaded with millions of copies of the same exact protein, called hemoglobin. And hemoglobin binds to oxygen and turns our blood cells into little oxygen transporters. And it basically allows us to move oxygen to all the tissues in our body. If we take an even closer look at those hemoglobin proteins, we find that they're made of 4 heme molecules, which have, right in the middle, iron. This iron molecule is what binds to oxygen, so each hemoglobin molecule can bind 4 molecules of oxygen. Additionally, iron is also an important part of proteins like myoglobin, which delivers and stores oxygen in muscles, and mitochondrial enzymes like cytochrome oxidase, which helps generate ATP. Now normally, when a red blood cell dies, some iron is recycled from it. But we also lose about 1 milligram of iron every day, some through the sweat, some shedded in skin cells, and some in shedded cells in the gastrointestinal tract, which get out of the body through feces. But most of us take in around 10 to 20 milligrams of dietary iron every day, and absorb about 10% of it, or about 1 to 2 milligrams, so it all evens out at the end of the day. Now, our diet contains 2 forms of iron. The first is heme iron, or iron bound to hemoglobin or myoglobin, and that comes from animal products like meat. Heme iron is in the ferrous or Fe2+ state. The other form is non-heme iron, which is free iron molecules in the ferric or Fe3+ state. Non-heme iron comes from plant-based foods like spinach and beans. Now, when food is broken down in the stomach, iron is released. Heme iron is absorbed directly into the duodenal cells, where it's broken down to release Fe2+ molecules. Non-heme iron, however, needs to be reduced to heme iron first. So the stomach's hydrochloric acid activates a group of enzymes in the duodenal cells collectively called ferroreductase, which live up to their name by reducing non-heme iron to Fe2+ molecules. Fe2+ molecules then bind to a protein in the duodenal cells called ferritin, which temporarily stores the iron. And when iron is needed in the body, some Fe2+ molecules are released from ferritin and transported into the blood, where the enzyme hephaestin converts them back to the Fe3+ state. Fe3+ molecules then bind to an iron transport protein called transferrin that carries iron to various target tissues and releases them there. Fe3+ enters these various tissue cells, where there's more ferritin that can store them for future use. Iron deficiency anemia can develop as a result of four main causes: decreased intake, decreased absorption, increased demand, and increased loss. Decreased intake is the most common cause of iron deficiency anemia worldwide, and it occurs in infants because breast milk is surprisingly low in iron. And it occurs in vegetarians, whose iron intake is mostly non-heme iron, which is harder to absorb. Decreased absorption can also occur when there's a decrease in stomach acid production, like after a gastrectomy, where a part of the stomach is surgically removed. Finally, decreased absorption can also occur with inflammatory bowel disease or celiac disease, both of which cause inflammation and destruction of duodenal cells. Next up, increased demand can occur in children and adolescents because they're rapidly growing and increasing in blood volume, which requires them to make more hemoglobin. Alternatively, it may occur during pregnancy because of the increased iron requirements for fetal development. Finally, increased iron loss generally occurs in people with chronic slow bleeding because iron is lost along with red blood cells. This includes females with frequent or heavy menstruation, or people with bleeding gastric ulcers, and most importantly, elderly males with colon cancer, because the tumor can bleed and cause anemia. In fact, the first symptom of colon cancer is often iron deficiency anemia. Another cause of iron deficiency is Helicobacter pylori infection, which classically causes gastric ulcers and gastrointestinal bleeding. This bacteria also traps dietary iron for itself, preventing it from even reaching the duodenum. Finally, in developing countries, a common cause of blood loss is hookworms. These worms latch onto the intestines and suck out the blood. Yikes! Now, regardless of the cause, iron deficiency leads to impaired hemoglobin production. Since there's not enough hemoglobin for a normal-sized red blood cell, the bone marrow starts pumping out microcytic, or smaller, red blood cells. These cells that contain less hemoglobin are called hypochromic, since they appear pale. So, iron deficiency anemia is also called microcytic hypochromic anemia. Okay, so besides being puny, these microcytic red blood cells can't carry enough oxygen to the tissues, and this is called hypoxia. Hypoxia signals the bone marrow to increase red blood cell production. And when even that increase doesn't help, the bone marrow kind of goes into overdrive and pumps out incompletely formed red blood cells. As a result, red blood cells of various shapes, called poikilocytosis, and sizes, called anisocytosis, enter the circulation. In addition to anemia, iron deficiency also results in defective production of mitochondrial enzymes that generate necessary ATP for growth and development. And this affects fast-growing tissues the most, like hair and nails. Iron deficiency anemia presents with typical signs and symptoms of anemia, like pallor, palpitations, shortness of breath, and easy fatigability. Specific symptoms for iron deficiency include koilonychia, or spooning of nails, hair loss, and pica, which is the consumption of non-food substances like clay or dirt. Sometimes, iron deficiency anemia can occur in the context of Plummer-Vinson syndrome, along with glossitis, meaning inflammation of the tongue, and esophageal webs, which are membranes made up of damaged esophageal epithelium and mucosa. Anemia is diagnosed using a couple of parameters in the blood. First, there are decreased hemoglobin levels, typically below 13.5 grams per deciliter in males and below 12 grams per deciliter in females. But those numbers can differ based on which guidelines you're using. Next, the mean corpuscular volume, or MCV, is decreased. This reflects the volume of a red blood cell. There's also low serum iron, low ferritin, and a high TIBC, or total iron binding capacity. TIBC indicates the amount of unbound transferrin in the blood. There's also a high red blood cell distribution width, or RDW, which indicates that red blood cells come in a lot of different sizes, and a peripheral blood smear shows microcytic and hypochromic red blood cells. Treatment for iron deficiency anemia includes addressing the cause and giving oral iron supplements, like ferrous sulfate. They can be taken with orange juice, which is slightly acidic and can help absorption. Common side effects of oral iron include nausea, diarrhea, and constipation. If oral iron isn't effective, or the side effects can't be tolerated, intravenous iron can be used instead. Severe cases can also require a blood transfusion. Alright, as a quick recap, iron deficiency anemia is a type of microcytic, hypochromic anemia caused by a decrease in the body's iron stores. It can be caused by decreased intake, which is seen in infants and vegetarians, decreased absorption due to decreased hydrochloric acid production or duodenal disorder, increased demand, which is seen in children, adolescents, and pregnant females, and increased loss in the case of females with frequent or heavy menstruation, bleeding gastric ulcers, and colon cancer. Treatment involves oral or intravenous iron supplements or blood transfusion in severe cases.
With sideroblastic anemia, sidero means iron and blastic means immature. And anemia refers to a condition where there's a decrease in the number of healthy red blood cells, or RBCs, in the body. So sideroblastic anemia is a type of blood disorder where there's a buildup of iron in the RBCs in the body, causing them to be immature and dysfunctional. This buildup occurs because these RBCs are unable to incorporate iron into hemoglobin, which is necessary for RBCs to transport oxygen. In order to better understand sideroblastic anemia, we need to first take a look at hemoglobin, the main protein within RBCs that's responsible for carrying oxygen. Now, with sideroblastic anemia, there's defective protoporphyrin synthesis, which results in impaired incorporation of iron to form heme. Sideroblastic anemia can be congenital or acquired. The most common congenital cause is an X-linked form, which means it happens on the X chromosome, and affects mainly boys since boys only have one copy of the X chromosome. The X-linked form is caused by mutations in the ALAS2 gene. The ALAS2 gene is involved in coding for delta ALA synthase. Without delta ALA synthase, there's a buildup of iron and not enough normal heme production. The acquired causes of sideroblastic anemia include excessive alcohol use, pyridoxine or vitamin B6 deficiency, and lead poisoning. Excessive alcohol consumption can lead to mitochondrial damage and nutritional deficiencies like vitamin B6, iron, and folate, which affects the mitochondria's ability to form heme. Vitamin B6 deficiencies can also commonly happen as a result of isoniazid treatment for tuberculosis, as isoniazid attaches and inactivates vitamin B6. Lead poisoning has also been shown to denature enzymes important in heme synthesis, like delta-aminolevulinate dehydratase and ferrochelatase, which are important for heme synthesis. Additionally, lead poisoning can also denature ribonuclease, which is an enzyme that degrades ribosomes. Without it, this leads to a buildup of ribosomes in the RBC, and can cause a characteristic studded appearance on histology, called basophilic stippling. Basophilic stippling is indicative of ineffective hematopoiesis, and can be seen in other types of anemias. These causes of sideroblastic anemia stops the iron from being incorporated to form heme, which allows the iron to accumulate in the mitochondria, resulting in Pappenheimer bodies seen on blood film. In the bone marrow, immature RBC's mitochondria surround the nucleus and get laden with excess iron deposits, which produces ringed sideroblasts on histology, hence the name of the disease. These sideroblasts have ineffective erythropoiesis, which means they don't develop normally to become a mature RBC, and end up dying in the bone marrow with a few escaping into the peripheral blood. A diagnosis of sideroblastic anemia can be reached with a combination of both clinical judgment and laboratory findings. Clinically, patients with sideroblastic anemia present very similarly to patients with hemochromatosis, as both these diseases involve a buildup of excess iron within the body. The excess iron damages multiple organs, which can cause fatigue, heart disease, liver damage, enlarged spleen, kidney failure, and diarrhea. Investigations should include a complete blood count, peripheral blood smear, and iron studies. On the full blood count, the mean corpuscular volume, which reflects the size of the red blood cell, is usually normal or low for the congenital causes. For acquired forms, the mean corpuscular volume is normal or high. While in the peripheral blood smear, we would expect to see erythrocytes with basophilic stippling, and Pappenheimer bodies, which are purple staining granules of iron found inside RBCs. Iron studies will show high serum iron, increased ferritin levels, and decreased total iron binding capacity. Treatment of sideroblastic anemia involves removal of toxins if there are any, and administering peroxidine, thiamine, and folic acid. Therapeutic phlebotomy or bloodletting can be used to manage iron overload, as well as deferoxamine, an iron chelating agent. In severe cases, a bone marrow or liver transplant might be needed. Alright, as a quick recap. Sideroblastic anemia happens when there's either a congenital abnormality or an acquired cause, like vitamin B6 deficiency, excessive alcohol use, or lead poisoning, which leads to an inability to incorporate iron to form heme. The overload of iron that's unable to be incorporated into RBCs can damage other organs. The lack of functional heme results in anemia and fatigue. For diagnosis, a full blood count and peripheral blood smear should be performed. Treatment involves removal of toxins and administration of pyridoxine, thiamine, and folic acid.
At the Family Medicine Center, Sophia, a 32-year-old black person of African descent, came to visit the doctor because she had been feeling fatigue as well as exertional dyspnea. Her medical history includes systemic lupus erythematosus. Next to Sophia, a father from Ireland brings his 14-year-old son, John, who's been less active and has bruised easily for the past month. John's medical history includes recurrent upper respiratory tract infections before the onset of current symptoms. During the clinical examination, his spleen cannot be palpated. CBC is ordered for both people, and they show low hemoglobin with normal MCV and reticulocyte count index lower than 2%. John also has leukopenia and thrombocytopenia. Both John and Sophia are suffering from anemia, which is defined as lower than average levels of hemoglobin, typically below 13.5 grams per deciliter in adult men and below 12 grams per deciliter in adult women. For children, this level varies based on the age. Now, anemias can be broadly grouped into 3 categories based on mean corpuscular volume, or MCV, which reflects the volume of a red blood cell. So, microcytic anemia is where the MCV is lower than 80 femtoliters. Normocytic is when the MCV is between 80 and 100 femtoliters, and macrocytic is when the MCV is larger than 100 femtoliters. Alright, the normocytic anemias can be further classified as hemolytic, where there's an increased destruction of red blood cells, and non-hemolytic, where there's decreased production of red blood cells in the bone marrow. When there's hemolysis, the bone marrow revs up and starts pumping out reticulocytes, which are immature red blood cells. But when there's a bone marrow problem, the reticulocyte count is low. So, for your exams, if you run into a normocytic anemia and the reticulocyte production index, or RPI, is higher than 2%, think hemolytic anemia, since the red blood cells are being destroyed and the body compensates by producing more. On the other hand, if it's a non-hemolytic anemia, the reticulocyte production index is lower than 2%, since the anemia is caused by a decrease in red blood cell production. Now in this video, let's focus on the non-hemolytic normocytic anemias, which are basically anemia of chronic disease and aplastic anemia. Keep in mind that although anemia of chronic disease is classified as a normocytic anemia, in less than 25% of the cases, it could present as microcytic. Let's start by looking at anemia of chronic disease, which is also referred to as anemia of inflammation. Whenever there's inflammation, there's an increase in the release of a protein called hepcidin by the liver. Hepcidin binds to a transmembrane protein called ferroportin, which can be found on intestinal mucosal cells, blocking iron absorption from the gut, and on macrophages, where iron is stored, blocking the release of iron into the blood. So, in anemia of chronic disease, there is iron in the body, but it's trapped in macrophages and can't be used by the bone marrow to produce the correct amount of red blood cells, which eventually leads to anemia. Now, the size of red blood cells initially is normal, and so at first, anemia of chronic disease is normocytic. But as the disease progresses, due to the inability to properly incorporate iron into hemoglobin, the bone marrow starts pumping out smaller red blood cells, so anemia of chronic disease can eventually become microcytic. Another hint that could tip you off is that when compared to other types of anemia, like iron deficiency anemia, erythropoietin levels are relatively low. This means that it's elevated compared to someone who's non-anemic, but it's too low to stimulate the necessary amount of red blood cell production. Now, anemia of chronic disease can be associated with chronic inflammatory conditions like rheumatoid arthritis and systemic lupus erythematosus, neoplasms like hepatocellular and renal cell carcinoma, and chronic kidney disease. Okay, moving on to aplastic anemia. Aplastic anemia is not really only an anemia, but it's actually a type of pancytopenia, which means that the red blood cells, white blood cells, and platelets are no longer produced. Aplastic anemia is caused by failure or destruction of the precursor to platelets and blood cells in the bone marrow. It's important to remember the list of causes for aplastic anemia, such as exposure to radiation, environmental toxins like benzene, and medications like chloramphenicol, which is an antibiotic. Chemotherapy agents like alkylating agents and antimetabolites, carbamazepine, an anticonvulsant, antithyroid agents like methimazole and propylthiouracil, and NSAIDs. Other causes of aplastic anemia include viral infections like EBV, HIV, hepatitis viruses, and parvovirus B19, and autoimmune disorders, where white blood cells attack the bone marrow. Fanconi anemia is also another potential cause, where there's a DNA repair defect causing bone marrow failure and pancytopenia. However, aplastic anemia can also be idiopathic, meaning it's not quite clear why there's bone marrow failure, but it's usually caused by an immune-mediated mechanism. For your exams, you should differentiate aplastic anemia from pure red blood cell aplasia. This is a rare form of anemia where the bone marrow ceases to produce red blood cells exclusively, while white blood cells and platelets are produced normally. It may be due to congenital causes, like Diamond-Blackfan anemia, where there's an abnormal synthesis of ribosomes. Acquired causes include autoimmune diseases, where white blood cells attack red blood cell precursors, tumors, and especially thymoma, where antibodies against erythropoietin are produced, and viral infections like HIV, herpes, and parvovirus B19. Once again, pure red cell aplasia can also be idiopathic, where no cause can be identified. Now, all anemias can present with fatigue, pallor, and shortness of breath, but other symptoms of the underlying cause can help you identify the specific disease. In anemia of chronic disease, you may have symptoms like joint pain in rheumatoid arthritis. For aplastic anemia caused by Fanconi anemia, we may see the characteristic clinical features, meaning short stature, increased incidence of tumors and leukemia, café au lait spots, and thumb or radial defects. Then, there could also be an increased risk of bleeding or bruising due to thrombocytopenia, and a high risk of infections due to leukopenia. For your exams, remember that in aplastic anemia, there's pancytopenia without splenomegaly because there's a lack of red blood cell precursors. This will help you differentiate it from other causes of pancytopenia that come with an enlarged spleen, like myelofibrosis, where extramedullary hematopoiesis will occur in the spleen, causing it to enlarge, and hairy cell leukemia, where there's an infiltration of the spleen by leukemic cells. For pure red cell aplasia, caused by diamond blackfin anemia, the test question will typically describe an infant with characteristic features, like growth retardation, craniofacial abnormalities, like hypertelorism and a flat nasal bridge, and thumb abnormalities. There's also predisposition to cancer, especially acute myelogenous leukemia and myelodysplastic syndromes. Whatever the cause, there would be no increased risk of bleeding or bruising since platelets are normal, and no higher risk of infections since white blood cells are also normal. Moving on to diagnosis. Let's start with anemia of chronic disease. The best initial test is a CBC with a peripheral blood smear that shows anemia that can be normocytic or microcytic, and an RPI that's lower than 2%. In your exams, the patient's history of having a chronic inflammatory condition, a neoplasm, or chronic kidney disease may be a clue to help you identify the disorder. However, the best clues for identifying anemia of chronic disease are the iron studies values. The serum iron is decreased because it can't be absorbed in the GI tract and can't be released by the macrophages. But ferritin, a marker of iron stores, is normal and eventually may be elevated as iron accumulates inside the body. Now, transferrin, a molecule that transports iron in the blood, is decreased because there's plenty of iron in the body, and TIBC, or total iron binding capacity, which indicates the amount of unbound transferrin in the blood, remains normal. Alright, moving on to aplastic anemia and pure red cell aplasia. For both, the best initial test is a CBC with a peripheral blood smear showing normocytic anemia, while the reticulocyte production index is lower than 2%. The key here is that aplastic anemia will additionally have low platelets and white blood cells. Iron studies are normal. There's no specific test for aplastic anemia and pure red cell aplasia. The diagnosis is basically a diagnosis of exclusion, since pancytopenia or isolated anemia with reticulocytopenia can also be caused by other diseases that infiltrate the bone marrow and decrease the production of cells, like myelofibrosis and cancer, either leukemia or metastatic cancer. So, in order to confirm the diagnosis, a bone marrow biopsy must be done. In aplastic anemia, the bone marrow aspiration is referred to as a dry tap because the bone marrow is hypocellular and the precursor cells are replaced by fat cells and fibrous stroma. In contrast, in pure red cell aplasia, the bone marrow is typically normocellular, with an absence of erythroblast, but normal maturation of platelets and white blood cells. Now, treatment of anemia of chronic disease focuses on addressing the underlying cause of inflammation. In certain cases, like chronic kidney disease, erythropoiesis stimulating agents like erythropoietin, or EPO for short, are considered. Blood transfusions should be used with caution. For aplastic anemia, treatment starts with red blood cell or platelet transfusions, which are often given supportively. Depending on the cause, it might also include stopping the offending agent, immunosuppressive regimens like antithymocyte globulin and cyclosporin, in case of autoimmune disease, or treating the underlying infection. Bone marrow stimulation with certain agents like granulocyte macrophage colony stimulating factor or GM-CSF might also be helpful. For your exams, keep in mind though that the only curative option is a bone marrow transplant. Similarly, for pure red cell aplasia, red blood cell transfusions can be given, and then, depending on the cause, immunosuppressants, thymectomy, or treating the infection may be considered. Alright, as a quick recap, non-hemolytic normocytic anemias include anemia of chronic disease and aplastic anemia. Anemia of chronic disease can occur when there's a chronic inflammatory condition, a neoplastic disorder, or chronic kidney disease. Aplastic anemia can occur when there's radiation, environmental toxins, medications, or infections that are toxic to the bone marrow, but it can also be idiopathic. A diagnosis can be made based on the patient's history, physical examination, and a CBC with a peripheral blood smear, as well as iron studies for anemia of chronic disease, and bone marrow biopsy for aplastic anemia and pure red cell aplasia. Treatment focuses on the source of inflammation in anemia of chronic disease and the underlying disorder in aplastic anemia and pure red cell aplasia. Now back to the patients. Both of them have normocytic non-hemolytic anemia. Due to her history of SLE, which is a chronic inflammatory disorder, Sophia probably has anemia of chronic disease, but it must be confirmed with iron studies, which will show decreased serum iron, normal or elevated ferritin, decreased transferrin, and normal TIBC. Now on the other hand, John has pancytopenia without splenomegaly and may have aplastic anemia. A bone marrow aspiration must be done to exclude diseases that infiltrate the bone marrow, such as leukemia. The aspiration will be a dry tap since the bone marrow is hypocellular and blood precursors are replaced by fat cells and fibrous stroma, and so the diagnosis of aplastic anemia will be confirmed.
Aplastic anemia is a pancytopenia, meaning all blood cell lines are decreased. So the term aplastic anemia, which just refers to low red blood cell count, is actually a misnomer. So with aplastic anemia, there's actually anemia as well as leukocytopenia, or low white blood cells, as well as thrombocytopenia, or low platelet levels. This condition takes many forms, ranging from mild to severe, depending on the cause. Now, red blood cells are produced in the bones of the body, mainly in the bones of the pelvis, ribs, and sternum, through a process called hematopoiesis. This process starts in the bone marrow, the innermost portion of the bone, where the hematopoietic stem cells reside. These serve as progenitor cells for all the different cell types found in the blood. First, hematopoietic stem cells, also called hemocytoblasts, can become lymphoid progenitors or myeloid progenitors. The lymphoid progenitors can develop into lymphoblasts, which can then differentiate into some white blood cells like T lymphocytes, B lymphocytes, and natural killer cells. The myeloid progenitors can differentiate into erythrocytes or red blood cells, megakaryocytes, which eventually give rise to platelets, or myeloblasts, which can then become other white blood cells like monocytes, neutrophils, basophils, and eosinophils. The most common cause of aplastic anemia is autoimmune destruction of the hematopoietic stem cells. The details of this mechanism are not fully understood, but research shows that there are alterations in the immunologic appearance of the hematopoietic stem cells because of genetic disorders or after exposure to environmental agents like radiation or toxins. This means that the hematopoietic stem cells start expressing non-self antigens, and the immune system subsequently targets them for destruction. As the immune system destroys hematopoietic stem cells, a whole host of complications arise. Due to the low red blood cell count, Tissues cannot properly oxygenate, so the heart pumps harder to circulate the red blood cells, leading to chest pain and shortness of breath. Low platelet count leads to an increased risk of bleeding from the most minor injuries and in mucosal areas. And low white blood cell counts lead to the body's inability to fight off common infections that can lead to sepsis. Now, there are many causes of aplastic anemia, but the disease is most often idiopathic or without an identifiable cause. Definable causes of aplastic anemia include radiation and toxins like insecticides or industrial agents that contain benzene. Drugs that may cause aplastic anemia include chemotherapeutic agents, anti-seizure medications, anti-inflammatory medications like indomethacin, anti-thyroid medications like propylthiouracil and methimazole, and antibiotics like chloramphenicol and sulfonamides. Infectious agents like the Epstein-Barr virus or HIV, and clonal or genetic disorders can also cause aplastic anemia. Finally, the most common genetic disorder associated with aplastic anemia is Fanconi's anemia. Fanconi's anemia is the most common inherited cause of aplastic anemia, which is a condition characterized by pancytopenia, predisposition to malignancy, and physical abnormalities like short stature, microcephaly, or a small head, developmental delay, cafe au lait skin lesions, and absent or hypoplastic thumbs. Symptoms of aplastic anemia include fatigue, pallor on account of low red blood cell levels, mucosal bleeding or petechiae due to low platelet counts, and recurrent infections due to low white blood cell counts. Aplastic anemia may be suspected based on a complete blood cell count, which shows low red blood cell counts, leukocytopenia, and thrombocytopenia. Erythropoietin or EPO levels are also increased. EPO is a hormone released by the kidney that tells hematopoietic stem cells to grow and divide into new red blood cells. With aplastic anemia, there aren't enough hematopoietic stem cells to generate appropriate amounts of red blood cells, so more and more EPO gets produced in an attempt to compensate. There may also be decreased reticulocyte count. Reticulocytes are young red blood cells, so this demonstrates decreased red blood cell production. Bleeding time may also be increased due to low platelet counts. Definitive diagnosis requires a bone marrow biopsy, which demonstrates profoundly low counts of hematopoietic stem cells with the normal cellular morphology in the absence of any infiltrative disorder like malignancy or fibrosis. This is also referred to as an empty marrow or dry tap. Treatment of aplastic anemia is largely dependent on the age of the person affected, as well as the clinical history. If the condition is thought to be due to a medication or toxin, these substances or exposures should be removed from the affected person immediately. For people under the age of 50, first-line therapy is a stem cell transplant. For those greater than age 50, first-line therapy is immunosuppressive therapy, with medications like cyclosporin or glucocorticoids, as well as medications that help to stimulate increased hematopoiesis, like granulocyte colony stimulating factor. Blood transfusions may be necessary for severe cases. Alright, as a quick recap, aplastic anemia is actually a form of pancytopenia that results from autoimmune destruction of the hematopoietic stem cells. Low red blood cell numbers cause poor tissue oxygenation. Low white blood cells cause an increased susceptibility to infections, while low platelets leads to an increased risk of bleeding from the most minor injuries and in mucosal areas. Most often, aplastic anemia is caused by medications, toxins, viruses, and genetic disorders. Treatment involves either stem cell transplant or immunosuppressive therapy.